So first of all, on the occasion of Endometriosis Awareness Month, we are very happy to oblige that Latur Obstetrics and Gynec Society has given the opportunity to arrange such a wonderful scientific event. So on the wonderful morning of this Sunday, that is 21st March, I welcome to all delegates and all the panelists. So given the opportunity to Sun Pharma to assist you. So with that welcome note, I request to
Dr. Prachi will join in now.
Yeah, Dr. Prachi.
Yes. Good morning, everyone. I welcome you all on behalf of Latur OBGY Society. Today we have gathered here for the webinar on endometriosis. In this webinar, we have two sessions. Session 1 will be moderated by chairpersons Dr. Bhalchandra Madam and Dr. Jaju Madam. Our speakers are Dr. Aniruddha Kulkarni Sir, Dr. Ritu Santwani Madam, Dr. Krishna Mandade and Dr. Nilesh Balkavde. Session 2 will be a case-based discussion moderated by Dr. Ganpat Sawant Sir and Dr. Kalyan Barmade Sir. So now I hand over the session to Dr. Swati Gore Madam, President Locks, for the further proceedings.
Sorry. Hello everyone and good morning. I'm really sorry for the delay of today's webinar, but I think now all the problems are solved. So on the occasion of Endometriosis Awareness Month, I welcome you all for this webinar, which is Endometriosis and Enigma. We have tried to include all the aspects of this subject in the presentation and the panel discussions. And I welcome all our speakers, Dr. Aniruddha Kulkarni, Dr. Ritu Santwani, Dr. Krishna Mandade, and Dr. Nilesh Balkavde. I also welcome our moderators for the panel discussion, Dr. Ganpat Sawant Sir, Dr. Kalyan Baramde, Dr. Vagesia, Dr. Sar Deshpande, Dr. Kade, Dr. Kale, Dr. Borse, and Dr. Darde. I welcome our MMC observer for today's webinar, Dr. Deepak Gugre Sir. And I also welcome our chairpersons for today's webinar, Dr. Bhalchandra Madam and Dr. Vasudha Jaju Madam. We have been granted MMC credit points and ICOG credit points for this webinar. So a big welcome to all the delegates. And I really hope we have a good feast, academic feast today. And now I hand over to Prachi to carry forward the program. Prachi, you can.
Madam. Yeah. Now we will start with the first session. For this session, chairpersons are Bhalchandra Madam and Jaju Madam. Bhalchandra Madam is one of the senior most practitioners in Latur. She is the director of Bhalchandra Hospital, Latur, and she is practicing since last 25 years. I will hand over the session to my colleague, Dr. Swapna, to introduce Jaju Madam.
Good morning, everyone. Our next chairperson is Dr. Mrs. Vasudha Jaju. She is consultant obstetrician and gynecologist, running a 16-bedded, well-equipped Jaju hospital, practicing in Latur since 1979. She has done her schooling and medical undergraduate education at Hyderabad and post-graduation degree of DGO from Marathwada University. She has conducted and attended many diagnostic health camps in the vicinity of Latur. She was the chairperson of first Marathwada Regional Conference of Obstetrics and Gynecology held at Latur. She is past Vice President of Indian Medical Association, Latur. Welcome, ma'am. Now, I would like to hand over the session to Bhalchandra ma'am for introduction of webinar.
Very good morning. Dear colleagues, endometriosis is very common problem amongst the infertile patients. And it is responsible for 5-6 D diagnosis in our histories. D is for severe dysmenorrhea, another D is for deep dyspareunia, then dysphagia, then dull eggs in the dull eggs in the chronic pelvic pain, then disorders of menstruation and dysuria. Sometimes severe endometriosis also leads to severe depression also. So today we have to tackle for all these diseases which we encounter in our practices. Ideally, when we see many patients of infertility, it amounts to 30 to 40% of the incidence of infertility is due to endometriosis. It is also responsible for 25% of patients of chronic pelvic pain. Many times the diagnosis is in dilemma. Nowadays, we have new modalities of diagnosis, MRI, CT scan, they all help in diagnosis of endometriosis at deep places. Today, there are many new developments in the treatment of endometriosis. Still, it is a problem for every one of us. So, I request Jaju Madam to introduce Dr. Aniruddha Kulkarni sir for today's webinar.
Jaju madam.
I think Jaju madam is having trouble connecting. Our first speaker is Dr. Aniruddha Kulkarni sir. He is director and faculty at Scholar MD. His areas of interest are intervention radiology in areas of neck, fetal, and genitourinary. He has published 2 chapters in the textbook of radiology. He has 23 index publication in his name. Reviewer of British Journal of Radiology, has been national and international faculty in ultrasound mega conferences. Sir?
Can I start?
Yes, sir. Yes, sir.
Actually, I need to share the screen. Can you see the screen, please?
Yes.
Yes, sir. So you can start now.
Very good morning to all of you and the technical now and then. In this COVID pandemic area, we are quite habituated to conduct good seminars, and I'm really thankful to everyone of Latur. I think Latur has got a lot of affinity for me because my first presentation in my life in 1999, I did in Latur IMA. That was with Dr. Ajit Bhagwat and Dr. Jiten Kulkarni. So myself, Dr. Aniruddha Kulkarni, speaking on endometriosis imaging channel. Nothing to disclose financially. Most of my presentation is on the various demos. So as when we remember the word demo, we always remember the movie Three Idiots, where the Rancho is quite habituated to give demo for everything. So during this entire talk of 35-40 minutes, I will be giving a lot of video demos for demonstration. No disclosures financially. The images and cine loops, they belong to my center. Few of the articles taken from the web have been duly acknowledged, and few of the images which doesn't belong to my center has been duly acknowledged as well. Thank you very much. The entire concept of deep endometriosis analysis has been based on a consensus group statement given in year 2016 by International Deep Endometriosis Analysis Group, which defines all the terms and particularly regarding how do you measure it, how do you do it, how do you define it, and all those terminologies has been used during my presentation of next 40 minutes. Usually there is a delay of almost up to the maximum tune of 8 years in diagnosing endometriosis, for the reason because there is a lot of overlapping as far as symptomology of endometriosis is concerned. And particularly from imaging side, particularly from the ultrasound side, there is lack of efforts in doing good ultrasound, wherein all the subtle signs of endometriosis are quite missed. And most of the times we always say that the ultrasound is normal, no abnormality detected, or tenderness which is seen should be correlated with the clinical signs. But if we take a dogmatic efforts in defining and demonstrating good ultrasound techniques so that we can define the subtle signs of endometriosis, we can diagnose it very well. The other modalities which are used are MRI and laparoscopy. So we have to have a vigilant look towards pelvis in defining the endometriosis. In terms of location, it can be a superficial endometriosis, ovarian endometriosis, or a deep endometriosis. And the deep endometriosis, that is a troublesome factor. In case of superficial endometriosis, usually the peritoneal surface of less than 5 millimeter depth is involved. In case of ovarian endometriosis, the classical fixity to the posterior surface of the uterus and cervical region along with ovarian endometrioma. And in case of a deep endometriosis involving anterior or posterior compartment of the pelvis. So what is IDEA protocol? So IDEA protocol is to go systematically in a 4-step fashion, and you can adopt any sequence for that matter. So what we do routinely is that we do a detailed analysis of uterus and adnexa, look for ultrasound signs of adenomyosis, presence or absence of endometrioma, and fix it to the underlying structure. That is step 1. What I do usually is that I look for POD signs of fixity. So assessment of a status of pouch of Douglas using real-time ultrasound based upon sliding sign is the step 2. Then as we are looking for a sliding sign, it is better to look at the deep infiltrating endometrioid nodules involving the anterior and posterior compartments using anterior fornix and posterior fornix view. That is the step 3. As we are evaluating this step 1, step 2, and step 3, most of the times we always look for site-specific tenderness as well as ovarian mobility. So if you have not taken into consideration during step 1, step 2, step 3, then you should dedicatedly look at soft markers, that is site-specific tenderness and ovarian mobility in step 4. So during routine ultrasound assessment, that is the step 1, we always look for whether the uterus is anteverted, whether it is retroverted, or whether it is anteverted and retroflex. So this is a cervix pointing towards the bladder, anteverted. The cervix is traversing posteriorly and dipping down of the fundus, that is retroverted. Here the cervix is anteverted, but the fundus is dipping down posteriorly, that is anteverted and retroflexed. Whenever there is anteverted and a retroflexed uterus with some signs of adenomyosis involving the posterior surface and lot of heterogeneity and fibrosis involving the posterior compartment, then we should always suspect, and it should give alarming signs whether there is a deep endometriosis in this patient or not. And always remember that routinely when we look at the ultrasound, it is usually through the anterior fornix. So when you should always try for all the maneuvers by shifting the transducer from anterior fornix to the posterior fornix. So cervix mobility and POD from the anterior fornix. Cervix mobility will not be demonstrated, but all the DIE signs involving the posterior compartment will be seen through a posterior fornix view. So the first thing that I need to look at is adenomyosis. So for years together, all the hysterectomy specimens which were landed up for a pathological assessment, many of them were used to show that there is a signs of adenomyosis involving the uterus. The sign could be a uniform globular enlargement of the uterus, or there is asymmetrical thickening of anterior wall or a posterior wall of uterus, to advancing stages where you can see multiple cystic spaces called the myometrial cyst involving the endomyometrial junction region, or even the myometrial substance. So the range of adenomyosis finding is from asymmetrical thickening, heterogeneous inhomogeneous areas with punctate hypoxic infiltrates, to classically what is called as a endomyometrial junctions, islands of hyperechoic nodularity, which is obviously seen. But the most specific sign to say that it is adenomyosis is the hyperechoic streaks which are extending from the endometrium into the endomyometrial junction halo, as well as adjoining anechoic spaces of endomyometrial junctions, anechoicity. As soon as you put a 3-dimensional view, here you can see the streak sign is quite beautifully seen. At the same time, the endometrium islands in the endomyometrial junction halo as well as into the myometrial space can be very well seen. So the thickening of endomyometrial junction, presence of a streaks starting from endometrium into endomyometrial junction halo, and presence of a endometrial islands within endomyometrial junction or the myometrium could be the most specific signs of adenomyosis. The next thing that we look at the routine examination is to look for an ovarian endometrioma. The classical description of ovarian endometrioma is that ovary is enlarged, it has got a large cystic unilocular lesion where the wall is usually thick, but the contents are homogeneous ground glass in appearance. So at the same time, when we are looking at the ovarian endometrioma, at the same time, we can look at the position of the ovary, the fixity of the ovary to the uterus and the POD, and its relation of the ovary to the normal other ovary or the even ovarian endometria in the other ovary. So this is how we demonstrate what is called as a ovarian mobility and adhesions. So here in this patient, you can see that the ovary is quite freely mobile, adjoining to its own surface as well as along the surfaces and serosa of the bowel. On the other side, you can see that the ovary is quite fixed to the uterine surface. At the same time, the movement of the uterus as well as the ovary is in synchronization and not distinctly separate from each other. So whenever you can demonstrate a large ovarian endometrioma and ovarian cyst on the other side, here you can see that the ovaries are quite stuck to each other. The mobility of the ovary is irrespective of its position. And thirdly, the ovary, along with its fixity to the other ovary, is also fixed to the posterior surface of the uterus or retrocervical portion of the uterus. So this we speaks about presence or absence of ovarian endometrioma, mobility of the ovary to the surrounding structure, as well as the ovarian fixity to the uterus and posterior cervical region. On many instances, you will find that the hydrosalpinx is a feature in case of endometriosis. Now, this hydrosalpinx can be inherited because of the endometriosis process involving the tube, or it could be because of the extensive adhesions that is causing fixity of the tube, uterosacral ligament, and ovaries to the retrocervical compartment. So hydrosalpinx can be primarily because of the involvement of the endometriosis or secondary because of adhesions and fibrosis. So if you have a fancy gadget like Volucel E8 or E10, then you can always give a 3D volumetric analysis of the hydrosalpinx in that region, which you can demonstrate beautifully. Now coming down to second step, that is the sliding sign. So I need to demonstrate the sliding sign in the anterior fornix, in case of anteverted uterus, into the posterior fornix, where you can see the movement of the bowel and the torus lower down over here. And in case of a retroverted uterus, the position can be again in the anterior fornix as well as in the posterior fornix. So whenever my transducer is in the anterior fornix, I do not see the cervix. At the same time, I can see the sliding of the cervix over the bowel quite easily. But when my transducer is in the posterior fornix, I do not see the cervix at all. At the same time, the sliding sign can be demonstrated over the bowel, and I can demonstrate the nodules of deep infiltrating endometriosis involving the bowel as well. So this is an example. Here you can see it's anterior. This is anteverted uterus. My transducer is in the anterior fornix. I can see the anterior cervix very well. Now here I can demonstrate that the cervix is quite freely moving over the peritoneal surface in the POD. This is again another example, but to show that how the bladder gets reflected over the anterior lower segment of the uterus, and here you can see it is dipping down over there. So whenever you can demonstrate the bladder very well in terms of hyperglycity involving the anterior surface, and it gets reflected from the anterior lower segment. That's the same place from where you can draw a line which goes through the internal os and goes posteriorly to the posterior cervical canal. So this is a point where probably it meets. So this is a line starting from here going posteriorly, and this is the place on sagittal scan you can demonstrate the torus. The torus is a point where both the uterosacral ligaments they get united. So as I am demonstrating the anterior cervix and the movement of the cervix over the pouch of Douglas, now my duty is to see how it behaves when my transducer is going into the posterior fornix. So what I have done is that I have slided my transducer from the anterior fornix into the posterior fornix, and now this is how the posterior fornix vaginal wall is getting minted over my transducer. So this is posterior vaginal wall getting minted over there. So now I am demonstrating well the normal bowel movement along the posterior fornix as well as into the POD, in the POD. So in case of anteverted uterus, my duty is to see the cervical mobility over the POD. And when my transducer is in the posterior fornix, my duty is to demonstrate the mobility of the bowel, posterior wall, and the retrocervical portion of the bowel and the content. So my transducer in anteverted uterus is in the posterior fornix. Now coming down to retroverted uterus, posterior fornix, vaginal wall, and the POD. Now here you can see my transducer is bending over there. So that is a posterior vaginal wall over there. The uterus is retroverted. There is little bit amount of fluid over there. But at the same time, even the uterus as well as the bowel and the posterior post-POD structures, they are quite freely mobile. So in case of a retroverted uterus, my transducers in the posterior fornix, I am able to demonstrate the vaginal wall and the POD sliding movements very, very easily. Now, in case of anteverted uterus, here you can see the movement of the cervix and the uterus and the rest of the part posteriorly is in opposite direction. Uterus is moving like this and the bowel is moving like this. So here the sliding test is what we can call as a positive sliding sign. Now here you can see there is a lot of heterogeneity and hyperechoic nature involving the posterior cervical component. At the same time, when my transducer is in the anterior fornix, the cervix and the structures posterior to the retrocervical component are moving in synchronization with each other. So sliding sign in this female is negative. So sliding side is negative. Now coming down to retroverted uterus, here you can see it's a retroverted uterus. This is my transducer is in the posterior fornix. I can demonstrate the sliding sign very easily as a normal one. But here again, as compared to this one, there is a lot of heterogeneity and hyperechoicity involving this segment of a retrocervical region. At the same time, the mobility of this component is usually in synchronization with the mobility of the uterus as well as the posterior wall and the cervix. So sliding sign in this patient is negative. So my duty of demonstrating sliding sign involving anterior fornix, involving posterior fornix is over. In case of anteverted uterus and posterior uterus. So the next step in case of IDEA is to demonstrate the nodules of deep infiltrating endometriosis. Now, whenever we say it's a deep endometriosis, when we say that the involvement of a nodule is more than 5 millimeter underneath the peritoneum. Usually, because of the cyclical bleeding and inflammation, it leads to fibrosis. And because of the fibrosis and the hypoechoic component of the endometriotic tissue, it appears like this. So this is a hyperechoic fibrosis, and this is a endometriosis components within the same. So it is classically described nodule as irregular hypoechoic nodule surrounded by the fibrosis. It can involve the anterior compartment involving the bladder or the ureters, or it can involve posterior compartment involving the posterior vaginal wall, ligament, that is uterosacral ligaments, as well as torus or the bowel. So this diagram I have taken again from the internet. So this is vagina, this is bladder, this is urethra. So first thing that you need to look at is a posterior vaginal fornix. So from the posterior vaginal fornix, what we do usually is that the bladder from the anterior row segment, as it gets reflected, I am going to draw a line which goes through the internal os, goes to the posterior part of the cervix, and this is the place where there is a torus, and the same line I am going to extend it below from the peritoneal reflection areas up to the rectum. Okay, so behind the cervix is a torus and uterosacral ligaments. So the another line I am going to pass from the external cervix, passing through the two and going into the rectal region. So again, we have a rectovaginal septum over there. This is a posterior fornix over there, and so these are structures. So the structures, this is anterior compartment up above over here, and these structures below this line, this is upper rectum, this is a lower rectum, and these all areas, particularly the posterior vaginal fornix, the POD, the retrocervical area, the lower part of the rectum, the torus, the uterosacral ligament, all these areas are the areas where I need to search for deep infiltrating endometriosis nodule. So my duty is to see posterior vaginal fornix, the area behind the cervix, that is the torus and uterosacral ligament, the lower part of the rectum, the upper part of the rectum, and if it is above this line, I need to look at the sigmoid. So whenever I get multiple nodules involving the retrocervical portion, pouch of Douglas, uterosacral ligaments, torus, lower part of the rectum, then multifocal involvement leads to what is called the frozen pelvis. Now, the posterior vaginal wall. As we have seen earlier, initially in most of the times, the transducer is anterior fornix. I need to shift my transducer into the posterior fornix and look for the normal posterior vaginal wall, which is a thin hypoechoic area, which mends with the transducer surface over there. Now look at the surface in lower senior lobes. Here on one part of the senior lobe, the hypoechogenicity of the mended posterior vaginal wall is normal, but as I am now here you can see, now as my sagittal section is sweeping to the other part of the posterior vaginal wall, then definitely there is a asymmetrical, remarkable hypoechoic thickening involving the posterior vaginal wall. This is nothing but a classical endometriotic deposits involving the posterior vaginal wall, which can only be demonstrated by shifting your transducer from anterior fornix to posterior fornix and evaluated the posterior vaginal wall and the deeper structure beyond that. So where to look for the torus? I have given a faint outline for the same. So this is my sagittal section. This is the area where the bladder is reaching and lifting up. This is a portion of anterior. This is a portion of internal os. This is a cervical canal. So I'm going to draw a line from a bladder intervening area of hyperechogenicity through the internal os and going into the retrocervical portion or along the posterior wall of the cervix. So this is a portion where the torus is there. So how to demonstrate the torus in a transverse or axial fashion? You rotate the transducer here in 90 degrees, then you will get a transverse section involving both the corners. So this is a transverse section. Then you shift your transducer lower down to the retrocervical portion, and then you can see the torus. So this is a torus, and these are the two uterosacral ligaments which go on either side. So this is again a sagittal section over there. This is a portion I need to look for the torus, and these are the uterosacral ligaments on the left side. And then again on the same side, on the same way, you can see the uterosacral ligament on the right side. So my responsibility is to look for the torus, look for any hyperechogenicity involving that or presence of a hypoechoic nodule involved in the torus. So this is a normal torus on the sagittal view. This is a normal torus. But as I have shown you earlier, as the amount of heterogeneity and hyperechoic component involving the retrocervical portion goes on increasing, your probability of defining it to be endometriosis involving the torus goes on increasing. Here you can see as compared to this, there is a lot of heterogeneity and hyperechoic component involving the same. So this is how you demonstrate uterus and the torus and the uterosacral ligaments. So whenever after demonstrating involvement of a torus or uterosacral ligament, the next thing that I'm going to look for is bowel nodule. The endometriosis involvement is always in the muscularis mucosa. So this is the serosa of the bowel. This is the muscularis mucosa of the bowel, which is because of hypoechoic outer, hypoechoic inner, and this hyperechoic line within that is because of the connective tissue. And then there is an area of a submucous area, and then there is a mucosa. So serosa, muscularis mucosa, submucosa, and mucosa. So you should look for dark hypoechoic nodule involving the serosa. Then it could be a superficial involvement of endometriosis. If it is involving the muscularis mucosa more than 5 millimeter, then it is deep endometriosis. So always look for something which is involving muscularis mucosa, and always remember it is usually most of the times involvement of the rectum, that is the lower rectum or upper rectum. On the remaining portion can be sigmoid or even appendix, ileum, or cecum. Whenever there is a multifocal involvement involving the torus, uterosacral ligament, and bowel, posterior vaginal wall, it leads to what is called the frozen pelvis. So whenever we say that there is a bowel nodule which is of a deep infiltrating endometriosis, which is involving the vagina, always look for fistulae. The fistulae can be very well demonstrating involving the submucosa or involving the postvaginal wall as well. And when we want to localize the nodule involving the submucosa, the nodule involving the muscularis mucosa, then always calculate a distance from the anal verge or the torus. I find it very difficult to calculate distance from the anal verge because it is far off and you are likely to make more mistakes. So I always tell my postgraduate students to calculate a distance of that nodule from the torus, which is easier one. So next, so my first responsibility to say whether it is superficial. The second one is to say whether it's deep. If it is deep, then I'm going to take measurements of that nodule, and then I am going to define its distance from anal verge or the torus. And the next one is to say whether it's a stenosing or not. So this is a classical lesion, but the muscularis mucosa is not that involved. It is less than 5 millimeter. So it's a superficial one. But here you can see the muscularis mucosa is quite beautifully involved in this U-shaped lesion. And this is nothing but a deep infiltrating endometriosis. Now, whenever we look for the bowel nodules, then we always try to see for number one, bowel adhesions, and number two, we have to see the distance from the anal verge. Now here you can see this is how I am going to trace the bowel from here and look for number one, the serosal surface, and number two, the muscularis mucosa portion. So if the entire extent of the muscularis mucosa starting from the anal verge high up to the sigmoid level is normal, then I am not worried about bowel nodules in this individual. But whenever I find this kind of a lesion, then always should look for. So now here you can see I'm tracing the bowel loops over there, and as I'm going up above, I'm able to demonstrate that there is a remarkable thickening involving the muscularis mucosa, and there is a what is called an Indian red hat kind of appearance. And here on many instances, if the muscularis mucosa lesion is quite extensive one, then it may lead to lot of fistulae involving the submucosa, as well as if adjoining structure like postvaginal wall is also involved. In all those individuals, probably you will see also fistulae involving the postvaginal wall. So my responsibility of demonstrating bowel nodule is over. I have calculated its distance from the anal verge or the torus. I have noted that there is an involvement of postvaginal wall or mucosa in that individual, and all the complications related to the bowel nodules have been attributed. Now, the next one is to measure the nodule, that is the length, depth, and weight. If the length of affected circumference, we need to calculate. And if the depth of the nodule is more than 10 millimeter, if the width of the nodule is compressing so much lumen, then you can see it's a stenotic lesion. And if the angle of the nodule the remaining serosa or muscularis mucosa is less than 90, then definitely we should always suspect that we are having surrogated markers of stenosis in this individual. So responsibility of number one, demonstrating the bowel nodule. Number two, measuring its distance from the torus or the external. Number third, taking the measurements of length, depth, and weight, and defining the involvement of the lumen per se, and defining whether the lesion is stenosing or not. Then coming to next, what is called the anterior compartment, where we need to look for urinary bladder and ureter. It is only 1 to 2% of the cases they are involved. Bladder is involved more as compared to the ureter. It is the fibrosis which is more responsible for the issues. And always when you are evaluating any suspected case of adenomyosis or endometriosis, we should always see to the renal hydronephrosis or hydroureter, whether it is present or not. Only few patients they will present with hematuria, because unless and until the endometriotic lesion reaches to the lumen of the ureter, it will not cause a hematuria. So this is the urethra. This is the where the ureter is going to be get attached to the urinary bladder. This is a portion of the trigone over there. So my area of interest is number one, where the ureter is getting attached to the urinary bladder. Number 2, the area between the ureteric attachment to the bladder and the urethra, that is a trigone. And many occasions, the two portions of the urinary bladder, the one which is extraperitoneal portion of the urinary bladder, or second one, the dome or the intraperitoneal portion of the urinary bladder. So this is how I assess, that is the lower one third of ureter, trigone, the extraperitoneal surface of the bladder, and the intraperitoneal or dome of the bladder. So it's as simple as that. Now, how do you look for the ureters or the bladder? The easiest one is to do a perineal scan first, look for the urethra, then push your transducer a little bit and go in a sagittal fashion. So as soon as you compress the urethra and the posterior bladder wall, then you get a structure like this. So this is a bladder over there, and a oblong structure which enters towards the urethra in this fashion is nothing but a ureter. So first look for urethra in a perineal scan, rotate by 90 degrees, go sagittally, look for the ureteric course which is traversing towards the base or the trigone area or towards the urethral portion over there, and look for the area of trigone, the lower one third of ureter. So how do you trace the ureter? If you want to trace it higher up, look for area which is medial to the internal iliac vessel, closer to ovarian fossa. Secondly, look at the closer to the cervical portion, closer to bladder base region, as I have demonstrated in this patient near the trigone. Whenever the ureteric dimension is more than 4 millimeter, you should call it as a involvement in terms of a hydroureteronephrosis. Now, ureter itself or external compression by deep infiltrating endometriosis nodules in the pelvis or the ovarian lesion, they are responsible for ureteric stricture over there. Now, here you can see this is a normal bladder. Here this is normal, and this is how you can demonstrate the ureteric chest as soon as you do a transverse rotation over there. So my responsibility is to demonstrate the ureteric jets on the both the side, demonstrate the urethra, look for the ureteric course over there, look for the posterior bladder wall over there, and look for any heterogeneous hypoechoic areas involving the extraperitoneal surface of the bladder over there. So then my responsibility is to look for hydroureteronephrosis. So there is a hydronephrosis, the ureter is seen to be dilated in upper one third, and it is also seen arcing over the interiliac vessels over there, which means that the ureter is dilated up to the pelvis, that is crossing of the iliac vessel, dipping down into the pelvis. So it's something obstructing lower down in the pelvis. Now here you can see it's a retroverted uterus, and you can beautifully see there is a extraperitoneal bladder involvement of endometriosis nodule over there. So can you see the hypoechoicity? It's a large lobular lesion involving the bladder serosa over there. This was nothing but a deep infiltrating endometriosis over there. Now, as we can see, there is a hydronephrosis over there. And in this patient, as I am demonstrating the ureter lower down, here you can see there is a lot of hypoechoicity involving the course of the ureter and adjoining hyperechoicity suggestive of a fibrosis. So this hydroureteronephrosis was due to deep infiltrating endometriosis involving the pelvis where ureteric stricture was there. In all cases of ureteric stricture, it is better to go ahead with MRI. The reason behind is that you can see in a single view the degree of hydronephrosis, the ureteric narrowing, and all the signs of endometriosis, either primary involvement or a secondary involvement because of deep infiltrating endometriosis. Then coming to last portion, that is the site-specific tenderness, or what you can say site-specific tenderness and mobility. As we have seen during entire talk, that we have demonstrated this in a detail, but still you need to ask to the patient gently and keep talking to the patient by keeping one hand over the lower pelvis and doing a bimanual test. So give a sustained pressure by left hand over the anterior abdominal wall in the pelvis, and give a sustained pressure by using transducer transvaginally through anterior and posterior fornix, and ask the patient whether this is sour, this is tender, whether there is a pain or not. And this specific tenderness you need to look for involving normal pelvic structures like bowel, cervix, torus, or structures like peritoneal surfaces where there is a heterogeneity or hypergeneity in terms of fibrosis and dark nodules. So look for site-specific tenderness, ask the patient, and then look for fibrosis and hypoechoic nodules involving that. At the same time, judge the mobility at the tender points along with the fixity of nodules if you have demonstrated during site-specific tenderness. So it's as simple as that. Now here you can see the cervix is quite stuck one. You can see there is a fibrosis in the retrocervical component and there is a uniform synchronized movement involving the same. And here, as we have seen earlier, both the ovaries, they are stuck to each other and the fixity to the retrocervical portion is also there as well as to each other. So this gives rise to what is called as the demonstration of site-specific tenderness and fixity. Now, as we have seen, it's very simple when you look at all these cases and images even on the internet or to demonstration. But how do you look for endometriosis when you want to pick the diagnosis in a non-symptomatic or early symptomatic patient? So always I emphasize to the PG students, always look for anterior fornix view where you want to demonstrate the cervix mobility, then shift your transducer to the posterior fornix position and learn how to demonstrate the mobility of the posterior vaginal wall, demonstrate the posterior vaginal wall lesions, also the sliding sign and mobility of cervix, bowel, and other structures through the posterior fornix. So the first and foremost step is to compare the normal things when you are looking at through anterior and posterior fornix. Then demonstrate torus. So start in non-symptomatic patient, start demonstrating the torus and tracing the uterosacral ligaments. Always start from the sagittal scan and then shift your transducer by 90 degrees and look at the transverse scan. And always look for posterior fornix of vagina for deep infiltrating endometriosis. So this is how you can start picking up lesions which are very subtle in nature. So how do you report those cases? So whenever you are asking the report from your radiologist, you should always ask for a detailed report. So what that detailed report should consist of? It should consist of uterus, its position and detailed analysis for adenomyosis, ovarian endometrioma and fixity, ovaries for its position, presence of endometrioma and fixity and tenderness involving the endometriomas. Then coming to retrocervical portion by shifting the transducer from anterior to posterior fornix, looking for torus, involvement of torus or uterosacral ligaments. Then fixity of structure in the retrocervical component because of deep infiltrating endometriosis involving posterior vaginal wall or a bowel. If there is involvement of bowel, detailed analysis of a bowel nodule in terms of its size, shape, position, angle, and presence or absence of a stenosing lesion. And if it's a multifocal DIE involving ovaries, retrocervical portion, torus, bowel, posterior vaginal wall, then it may lead to frozen pelvis. And always ask whether there is a hydronephrosis in that individual or not. So this is what minimum you should expect from your radiologist when or before stating that in this patient there is endometriosis or there is no endometriosis. Now this is the last case to demonstrate. Here you can see classical endometriotic lesion over there. Here you can see there is a muscularis mucosa thickening involving this portion, involving the bowel. And here both the ovaries, they are stuck to the retrocervical portion with restricted mobility. So this entire leads to what is called the frozen pelvis. So what is the role of MRI? I personally do not have much experience as far as MRI. So I have taken this substance from Dr. Sharad Kondekar. MRI is mainly used as a problem solving tool for assessment of disease extension. In MRI, starting from small bowel, IC junction, sigmoid, other things can be seen very well. Apart from the dynamic investigation like ultrasound, in case of all preoperative assessment, the mapping of disease extension is very, very important for surgical intervention, and that can be possible with MRI very easily. It's very important for the reason when the lower portion of the rectum is involved. So whenever the lower portion of rectum is involved, probably we may require a surgical help from a gastroenterological surgeon. So it's a problem solving tool. It's not a primary modality, and always 3 Tesla MRI is better. Now here you can see a T2 weighted image involving the ovary, where fluid level is quite seen in case of endometriosis. It's a hyperintensity on T1, and on fat suppressed image you can see in the anterior wall the classical adenomyomatic lesions. Now the crux is, you should never accept a report stating that endometriosis cannot be seen. I think this should be the first and foremost message that it should go across after this webinar. Endometriosis or deep infiltrating endometriosis can be demonstrated, can be staged, and can be graded on ultrasound. MRI is always a problem solving tool, and the extension or the mapping that is possible on MRI can definitely be helpful for decision making as far as surgical outcome is concerned. And as a routine practice, whenever we do ultrasound in normal individuals, always start assessing the anterior fornix approach, the posterior fornix approach, the mobility of the cervix over the retrocervical region, the demonstration of a posterior vaginal fornix and posterior vaginal wall, and always look for the posterior compartment for involvement of a deep infiltrating endometriosis. So never ever accept that the deep infiltrating endometriosis is not seen on ultrasound. It very well can be seen. Needs little bit of focused approach to the same. Thank you very much. You must innovate every day and demonstrate the lesions, and it's pretty easy. As soon as you start looking for it, you will find it in due course of time. Thank you very much once again, and have a good, wonderful Sunday as far as endometriosis is concerned. Thank you.
Thank you, sir. So there are 2 questions. Can we take them?
Please go ahead.
Sir, first one is they have asked, one of the delegates, kindly focus on scar endometriosis.
No, actually, see, scar endometriosis is a type of, when we say scar endometriosis involving the anterior lower segment, then probably it's a different thing. But most of the times it is superficial endometriosis. I mean, scar endometriosis involving the laparoscopic scar, or scar endometriosis involving the anterior abdominal scar, involving the laparoscopic port or cesarean section scar. Usually it's a superficial endometriosis where the peritoneum is not involved, unless it is involving the anterior lower segment section scars. Here they are, hyperechoic fibrosis is less as compared to what we get in deep infiltrating endometriosis. So the component is hypoechoic, and the components, they are usually spiculated margins, and on many occasions you get discharging areas involving the anterior lower abdominal scar. So I have not covered that because it was involving anterior abdominal wall.
And sir, Dr. Borse has asked, he has said, can some tips be added about adenomyosis, superficial and deep, that causes confusion in decision making in Paris women?
I'm just, is my slide seen once again?
No, sir.
Just a minute. Now, can you see this one?
Yes, sir.
Okay. So in cases of adenomyosis, for years together, we used to say bulky uterus, but now, because the transfer and transducer resolution is very good, and secondly, the expertise in terms of demonstrating adenomyosis in ultrasound are on a very great rise, we can demonstrate very dogmatically adenomyosis on transfer and ultrasound. The first thing that you should look always is the asymmetrical thickening adjoining to the endometrial substance. So if here you can see the posterior wall of the myometrium is quite thickened one as compared to the anterior one. The overall echogenicity of the myometrial component is heterogeneous. There are a lot of hypoechoic areas infiltrates with the hyperechoic substances. I am not able to demonstrate the endomyometrial junction zone very well. So if you have fortunately have a 3D with you, Then thickening of the endomyometrial junctional zone, which is a classical feature on MRI, can be very well seen on a 3D as well. So first thing that I should look for is a asymmetrical thickening of interior or posterior wall of the uterus and lot of heterogeneity with absence of an endomyometrial junction halo. So that's the first thing. So after getting to a conclusion that this is something which is not normal, then look for very precisely the endomyometrial junctional zone right over there. Now here the endometrial echostripe is quite beautifully seen, but at the same time, the endomyometrial junctional zone, which is classically described because of the inner compactum level of the myometrial tissue over there, is always and always hypoechoic substance. So if the hypoechoic substance is lost and there is a thickening over there, the next thing that you should look for is that this, can you appreciate the hyperechoic strands over there? Multiple hyperechoic strands which are starting from the endometrial substance and traversing way into the endomyometrial junction as well as into the myometrial substance. So that's the next thing that you need to appreciate. So after that, as you look for the same, the next thing that you should look for is what is called as a islands. Now here you can appreciate the endometrial very well. The endomyometrial junction zone is lost, but hyperechoic nodules which are distinctly separate from the endometrium can be seen in the endomyometrial junctional zone. I think it's nicely seen in this case. So after this indistinct zone, I am looking for islands of endometriosis or islands of endometrial tissue in the endomyometrial junction zone. So that's the next one. And after that, this one, the next thing that I should look for is what is called as a focal adenomyotic anechoic cystic spaces initially adjoining to the endometrial cavity in the endomyometrial junctional zone, or later on large cysts which are usually less than 5 millimeter way off from the endomyometrial junction zone as well. So this is how the spectrum of adenomyosis that behaves. Initially asymmetrical thickening, then inhomogeneous myometrial substance, loss of endomyometrial junctional zone, then multiple hyperechoic and hypoechoic infiltrates involving the endomyometrial junction and other area. Look for hyperechoic strands which are extending from the endometrial tissue into the endomyometrial junctional zone. Presence or absence of adenomyotic islands or endometritic islands in the endomyometrial junctional zone as a nodularity over there, and presence of a tiny cystic spaces in the endomyometrial junctional zone, or later on larger anechoic cyst involving the endomyometrial junction zone as well as the myometrial substance. And then again, if you have a 3D, then these speculations extending from the endometrial cavity into the endomyometrial junction zone as well as the islands of adenomyosis in the endomyometrial junction zone can be picked up very well. Thank you.
Thank you. Sapna?
Thank you so much, sir, for shedding light on imaging modalities of endometriosis. It was very informative lecture. Now I request Dr. Rakhi Sada to display e-certificate for sir.
Just a minute.
Yeah, I have shared.
Yes, sir. So kindly do accept.
Oh, thank you. Thank you very much. Thank you.
Yes, sir. Thank you so much, sir.
Thank you, sir, for excellent presentation.
Thank you. Thank you.
Sapna, you can.
Yes. Now I would like to hand over the session to Bhalchandra ma'am for further proceedings.
We will call Dr. Ritu Santwani madam for her next lecture. Her lecture will be on role of Cabergoline in endometriosis. Madam Ritu Santwani is director of Sham Well Women Clinic in Pune. She is IVF specialist. She has 20 years of extensive experience in obstetrics and gynecology services, along with specialization in cosmetology and IVF test tube baby center. She is very passionate about sharing her knowledge and welfare activities. She is host and keynote speaker of more than 1,000 seminars, webinars, summits. She attends training sessions and public awareness sessions. Dr. Ritu has written more than 200 articles and columns for various health journals and newspapers. Dr. Ritu have earned various awards and recognition for her significant contribution in health and social care services. She is MBBS MD and she is ART NUHS Fellow FICOG and PGD. She is well versed in clinical cosmetology and medical cosmetology. She is RCOG graduate also.
Ma'am, I think this much is enough.
Yeah, she is.
Yeah, madam, you can start.
Yes. First of all, a very happy Sunday to all of you. I know this is a busy day of the Sunday. We are getting only the time of Sunday. So first of all, I want to thank the President, Dr. Swati Gore Madam, and dear friend, Dr. Rakhi Sada, for inviting me here. Coming to Latur is like that. I was first of all invited in the Latur. I'm having so many friends in the Latur. Abhi मैं किसका नाम लूँ, कोड़ा नाम नको घेऊ. First of all, I was invited in the Latur some years back by my very dear friend Dr. Meghna Gogre. I can see Dr. Meghna and Dr. Deepak both are here. There are so many friends, Dr. Kalyan Barmade, Dr. Bhau Rao Yadav, Dr. Rajesh Darde, Dr. Kanchan Jadhav, I'm correcting, Dr. Surekha Kare, so many friends are there. And Dr. Jakaria is also my good friend, Dr. Anupma I can see here, and Dr. Razia Sheikh, so many times I have come, Dr. Rashna Jaju, so many friends are here. So thank you so much for inviting me here. So now I'm coming directly to the topic. I know the topic is very theoretical. आता हिच्यामध्ये मी काय practical points देऊ शकते, I will try my best. Thank you once again, Dr. Rakhi, for inviting me. I'm sharing my slides. Yeah. I'm making this short.
Your slides are visible, madam.
Yeah.
It's a full screen.
Yeah. So friends, as all of us know, we are going through the second phase of Corona. So my presentation always starts. First, I will worship to Mata Rani that she will save us, all of us from this Corona. Then I will start my presentation. So, Ya Devi Sarvabhuteshu, Chikitsa Rupin Sansita, Namastasei, Namo Nama. So friends, today I am going to discuss a topic, the role of Cabergoline in the endometriosis management. I am able to see here around 65 logins. So quickly write in the chat box, how many of you are using this Cabergoline in the chat box for the treatment of endometriosis? Please write in the chat box, how many of you are using this Cabergoline? So at least I will be able to make attentive everyone. How many of you are using Cabergoline for this endometriosis management? Yes, there are 65 logins I'm able to see, but on the chat box only 23 answers are yet. So friends, as we all know, this March month is an endometriosis awareness month. Endometriosis is a chronic debilitating disease which adversely affects the quality of the life of the woman. I hope all of you agree with me on this. Yes or no? At least I can listen some voices.
Yes.
Yes, good.
Yes.
Yeah. Because in the webinar, there is no eye-to-eye contact. So we have to make the session very interactive. So there's a very famous quote by Sir Winston Churchill. as the topic of today is also, this endometriosis is an enigma which is wrapped in the riddle and surrounded by the mystery. So, as we all know, yes, the endometriosis, the definition is the presence of endometrial type mucosa outside the uterine cavity, the predominantly but not exclusively in the pelvic compartment. Yes, as we all know, it is an estrogen dependent chronic inflammatory condition that affects a woman in their reproductive period, associated with pelvic pain and infertility. So now what the study suggests regarding the prevalence and incidence? Yes, the determination of prevalence and incidence figures has been hampered by exclusive reliance upon the surgical visualization of the lesions for the definite diagnosis. The real incidence of endometriosis is not known, and it is estimated that presence of more than 15% of the reproductive age group women and in up to 50% of the women with pelvic pain. All these studies have been quoted in the Journal of the Fertility Sterility 2. So again the study have taken from this Journal of the Family Physicians. Here we can see, I'm coming to the topic, but first I have to explain that how it is Cabergoline is going to act. So this mother or sister is having the endometriosis history, and if the how the incidence is increases if the menstrual flow 6 days or more, menstrual cycles less than 28 days cycle of 28 to 34 days, consumption of the alcohol or the OCPs, and the use of the tampons. These all factors they have included in this study. So here we can see this. I think Dr. Kulkarni sir has explained very nicely, so I can omit this. Very nicely slides he explained. So as we all know, for this endometriosis pathophysiology, yes, the angiogenesis, arteriogenesis or vessel maturation and the lymphangiogenesis comprise the continuum of vascular development with overlap and interaction between the mechanisms by which they are controlled. So the process of the clinical interest, because they play a role in the endometrial repair, the placental development, and in the gynecological disorders, including the endometrial cancer, endometriosis, and abnormal uterine bleeding. So now how this acts? So we can see uh, from this the additions, angiogenesis, and peritoneal invasion is stimulated by some factors like hypoxia, injury, inflammation, endometrial receptor alpha expression. Then again, it causes the endometrial cells, peritoneal cavity, and inflammatory response. This additions, angiogenesis, and peritoneal invasion in turn causes the endometriotic implants, pro-angiogenic factors, neovascularization, survival in the peritoneal cavity. So again, the pro-angiogenic factors, all these factors has been reported: VEGF, interleukin 1 beta, interleukin 8, TNF alpha, interleukin 6, HGF, erythropoietin, and angiogen. These all factors has been reported. So the pathophysiology suggests the new vessel formation has long been recognized as a feature of endometriosis. Endometriotic implants are often surrounded by a web of blood vessels. Microscopic studies have confirmed the neovascularization around and within the endometriotic lesions. The endometrium has an angiogenic potential, and endometriotic lesions grow in the areas with rich vascularization. So, as we have just discussed, so among the angiogenic proteins synthesized by endometrial and endometriotic cells, the VEGF is the prototypical, most potent, and most highly regulated endothelial cell mitogen, and also an important vascular permeability factor. So now this VEGF concentrations, the studies have shown it is particularly high in the hemorrhagic and red implants, Higher concentrations of soluble VEGF accumulates in the pelvic fluid in the patients with endometriosis. In addition to its production by endometriotic implants, activated the peritoneal macrophages and neutrophils also have the capacity to synthesize and secrete VEGF. So, the study has been presented by Ana Lucia and Fernando Reis, a very recent study. They have shown the peritoneal fluid of patients with endometriosis is a complex suspension carrying the inflammatory cytokines, growth factors, steroid hormones, pro-angiogenic factors, macrophages, and endometrial and red blood cells. These cells and their signaling products concur to promote the spreading of new blood vessels at the endometriotic lesions with surroundings, which contributes to this endometriotic implant survival. Yes, the experimental studies of several anti-angiogenic agents demonstrated the regression of endometriotic lesions by reducing of their blood supply. So currently, what are the medical treatments are available for the endometriosis? Before I go through these slides, I want to the opinion of everyone that how many of you are using this GnRH agonist and how many of you are using the combination of this GnRH agonist and Cabergoline, and with which you are finding the good results. So I want to know the everyone's opinion. Please write in the chat box that how many of you are using this Cabergoline alone and how many of you are using that with the combination therapy. So the current medical treatments are available with the patients with endometriosis are the analgesics, yes, the OCPs, androgenic agents, danazol, progestogens, GnRH hormone analogs, leuprolide, goserelin, triptorelin, nephrilin, and antiprogestogens, gestagenone has been reported. So, what are the limitations with this concerned medical therapy? Yes, with the NSAIDs, as we all know, the nausea, vomiting, GI irritation, drowsiness, headache. With combined OCPs, yes, the nausea, weight gain, fluid retention, depression, breakthrough bleeding, breast tenderness, headache, and decreased menstrual flow has been reported. And with the progestins, again, this nausea, weight gain, fluid retention, breakthrough bleeding, depression, amenorrhea, delayed return of ovulation. GnRH agonist similarly causing the hypoestrogenism, which in turn causes the vasomotor symptoms, vaginal dryness, decreased libido, irritability, loss of bone mineral density, aromatase inhibitors, hypoestrogenism, induction of ovulation, danazol, hyperandrogenic side effects, acne, edema, decreased breast size. As in every day in our OPD, we are getting one or the other companies coming. There are so many studies have come regarding the use of this Dynogest also. Some herbal preparations are also coming. So I want to know the everybody's opinion with which drug you are finding the good results. So friends, please do write in the chat box. This will be a mutual discussion, not only that monotonously I am speaking. Please do write in the chat box. Now, what are the limitations of the surgical therapy? Yes, the fulguration, ablation, and excision. Risk associated with anesthesia and the risk of infection, damage to internal organs, new adhesions, hemorrhage, excision or drainage and ablation, risk associated with anesthesia and risk of infection, damage to internal organs, new adhesions and hemorrhage. Yes, LPSN nerve pathway interruption has also been reported. Bleeding in the adjacent penis plexus, urinary urgency, constipation, painless first stage labor, hysterectomy, bilateral oophorectomy. Again, it has been reported that persistent or recurrence of the pain in 10% of the patients and residual ovarian tissue. So now what the studies have caught, what's the role of this Cabergoline? So this study I have taken from the PubMed. Yes, the study has shown the dopamine agonist administration causes a reduction in endometrial implants through modulation of the angiogenesis in experimentally induced endometriosis. So new trends in the pharmacological treatments of endometriosis. The study has been from the Archives of Perinatal Medicine in 2020 and 2014 also by the Stefano Lucy has been reported that the emerging evidence that the estrogen can both promote and inhibit the endometrial vessel growth under different circumstances demonstrates the complex regulation of endometrial angiogenesis. During this angiogenic process, endothelial cells proliferate, migrate, and attach to external cellular matrix, inducing matrix remodeling and formation of new lumen in the endometrium of the woman with endometriosis. Uh, Actually, knowing this all is very, very important, especially in the Pune city. It is very, very important where we are getting all these Google savvy patients. Yesterday only I wrote one patient. So she told me, ma'am, I have just searched. She was waiting outside. I haven't found the enough studies that Cabergoline will be going to work on my endometriosis. Luckily, I was ready with my presentation. I told her, yes, I will be sending you on the WhatsApp by night so many studies. So regarding this anti-angiogenic agents, yeah, different anti-angiogenic treatments such as VEGF agents and other angiostatic drugs have been tested in experimental models of endometriosis with successful results inhibiting the new vessels formation. These drugs, mainly with cytotoxic properties, target specifically endothelial cells without the penetrance in the tissues. So the studies have shown that this dopamine and dopamine agonists, the bromocriptine and cabergoline, are able to promote this VEGFR to endocytosis in endothelial cells, blocking the critical step in the neoangiogenesis process, reducing the expression of VEGF and ectopic endometrium. Thiazolidinones, class of medications used in the treatment of type 2 DM have been shown to inhibit both the monocyte migration and peritoneal inflammatory cells. The study has done on the mouse model. Then the studies have shown regarding this use of this rosiglitazone also for 6 months. The studies have concluded the use of the thiazolidines for endometriotic pain relief in conjunction with attempts to conceive. So now coming to this VEGF blockers, a lot of studies have been reported with different products. 4-hydroxybenzyl alcohol with pericoxib, with epigalactogen gallate, SU668, and macrophage migration inhibitory factor. These studies have all shown by using of these agents, we can see the reduction of this lesion size, microvessel density, and the number of macrophages and expression of VEGF is reduced. This all you can see by the International Journal of Obs and Gynae, volume 2013. If you put this endometriosis management, we can get all these details. Other anti-angiogenic agents which have been reported, yes, xanthohumol, rapamycin, retinoic acid, progestogen, statin, and dopamine agonists. These all have been reported. So as we all know, the studies, as we are getting daily, so many companies are coming to us that this drug is having good result, other drug is having good result. So currently, I am doing one of the research study with this rapamycin at my center. Probably it will complete it by 22, then we can share the data of that also. So this progestogens, it reduced the proliferation of endometrial stromal cells and the suppress the transcription of VEGF-A and the microvessel density. Coming to this statins, yes, lot of studies have come for regarding this use of statins. Atorvastatin, lovastatin, which inhibits the inflammatory and angiogenic genes COX-2 and VEGF in the endometriotic stromal cells. Now, the topic which we are discussing today is dopamine agonist, the reduced microvessel density and angiogenic gene expression. Sorry, friends, the topic is very, very theoretical. So now, idea to use this dopamine agonist as an anti-angiogenic agent begin with the study by Basu et al. They have presented the study that the neurotransmitter dopamine strongly and selectively inhibits the vascular permeability and angiogenic activities of vascular permeability factor at the non-toxic levels. So now how this cabergoline is acting? Yes, The mode of action is by endocytosis on VEGF2 receptors, reduces the neoangiogenesis. It prevents the VEGF and VEGFR2 binding and causes the shrinkage of endometrioma. So there are actually a lot of studies, some studies in the favor of this, that it is Cabergoline is decreasing this endometrioma. Some studies are against of that also. So there is one study. So friends, how many of you are using this GnRH analog along with this Cabergoline? And how many of you are using this Cabergoline along with Dynogist? And how many of you are using this alone? Please write in the chat box. I will be waiting for everyone answers. Please do write so we can discuss after completing the presentation. Yes, the studies have shown thus the Cabergoline helps in decreasing the endometrioma size compared to LHRH agonist, a prospective randomized study. The study has done on 140 patients, group 1, in which they have shown the Cabergoline in the doses of 0.5 mg twice a week for 12 weeks, while in the group 2, they had given the LHRH 3 injections, 1 per month. Again, the studies have shown, we can see that have shown that the Cabergoline is most effective than LHRH agonist in decreasing the endometrioma size of more than 25% of its original size. The dosage they have been recommended, the 0.5 mg twice a week for 12 weeks. Here they have shown that Cabergoline studies up to giving the successful result to 64.7, while this LHRH agonist is up to 21.7%. Based on the basis on the success of this Cabergoline in controlling the endometrioma, apparently the diminishing the VEGF and thus with the main pathophysiology of the endometriosis is spread. Guidelines, what does the guidelines recommend? Yeah, so according to this FOXY guidelines of the under the aegis of the FOXY Endometriosis Committee 2014 to 16, it is included in FOXY recommendations on endometriosis management. Yes, the medical management again is in the favor of this 0.5 mg twice weekly. Studies have shown the endometriosis, the multidisciplinary research and development, and dopamine agonists in the treatment of endometriosis are really effective. The study has been Fatima Osmani and Amina Osmani and Mahmoudullah Razvi. They have shown the patients who desired of fertility, Cabergoline therapy often clear the cut advantage over other forms of therapy available, which delays the conception by their mechanism of actions. Cabergoline can be used pre-operatively, post-operatively, or alone or in combinations with COCs. Again, the studies have shown that dopamine agonists are effective in the treatment of endometriosis. Again, this study by Fatima Osmani, yes, they have shown that no adjuvant therapy is needed as it does not bring the hypoestrogenic and bone density changes. It is effective in the patients with elevated prolactin levels, reduces the pain by its action on nerve fiber. So the study has concluded that the other form of therapies delay the conception by their mechanism of action, usually do not give pain relief, while the Cabergoline through its action on the nerve fibers decreases the pain as well. The Human Reproduction Journal shows the study for the evaluation of anti-angiogenic properties of Cabergoline on the growth of established endometriosis lesion and investigate the molecular mechanism by which the Cabergoline exerts its anti-angiogenic effect. So by this study, they have concluded after the treatment that the implants were processed to assess the proliferative activity, neoangiogenesis, VEGFR2, phosphorylation, and angiogenic gene expression. So they have shown the recovered the active lesions were significantly decreased and 58.6 and the high 60 higher with the 60.4 with the Cabergoline. The studies have shown it lowers this proliferation index. A significantly lower proliferation index is observed in the studies have been reported. The proliferation index measures the proliferative activity of endometriotic cells. Then they have shown that these anti-angiogenic factors were significantly increased by this cabergoline low and high doses compared to the control. So it has been used for, as it decreases the formation of new blood vessels than control. You can see here that how it is acting. So these findings supports the testing of the dopamine agonist as a novel therapeutic approach to peritoneal endometriosis in the humans. Studies have come, as what the question I have asked, the comparison of the efficacy of the bromocriptine and cabergoline to GnRH agonist in the rat model. The study has been presented by Umid Agnon. They have concluded that with this dopamine agonist, the significant reduction in the implant surface area, reduction in implant size, and reduction of the score also. We can see here they have shown that while this they have compared with this GnRH analog and cabergoline, they have seen that before treatment, which was 22.5, it has been reduced to after median treatment 8.5, and with this cabergoline 20 to 11. So the p-value has been reported 0.001. So different authors have reported the different studies. The latest update from this March 2017, one study has been there for this from the Journal of the Pharmacotherapy. It has concluded that it appears the most promising molecules in the treatment of endometriosis in the near future. It has been reported the algolix, mifepristone, TAC 385, KLH 2109, ASP 1707, and cabergoline. So this again on the Fertility Sterility Journal also has been reported the new development in the medical treatment of endometriosis. This study has been shown that it is an effective option for endometriosis treatment. It reduces the endometrioma size by its anti-angiogenic action, reduces the expression of VEGF and VEGF receptor proteins too. The very vast study has been in the Fertility Sterility Journal of 2017. Again, the study, this study is done by my very dear friend, Dr. Amit Kayal. Those who are associated with me in the academic groups, yes, Dr. Amit is one of the active member of the academic group. So this study has been done by him. Does cabergoline effect helps in decreasing the chronic pelvic pain due to endometriosis compared to medroxyprogesterone acetate? A prospective randomized study. The study have shown for this cabergoline versus medroxyprogesterone in endometriosis. A study has done in the Kolkata Medical College for comparison of this cabergoline and medroxyprogesterone. So dopamine and its agonists such as cabergoline promote VEGF receptor 2 and endocytosis in endothelial cells, and therefore binding is prevented and neoangiogenesis is decreased. It has been found that daily treatment with cabergoline suppresses the cell proliferation and VEGF mediated angiogenesis. So it has been considered as a novel drug for the treatment of chronic pelvic pain due to endometriosis. In this study, they have include the patients from June 2015 to 2016, in which they have assigned into two groups. One is receiving medroxyprogesterone acetate 10 mg TDS, other is receiving this cabergoline 0.5 mg twice weekly. For 12 weeks, this study has been done, and response of pain was measured on a visual analog scale. You can see at the time interval of 1, 3, 4, and 6 months. Only few slides are left. Yeah. So the study have designed total, they have taken the 80 patients, in which 40 patients they have given the medroxyprogesterone 10 mg TDS for 12 weeks. And in the 40, they have given 0.5 mg twice weekly for 12 weeks. Similarly, this study has shown that how is the decrease of this VAS receptors, VAS scale, just a second. So the patients receiving with medroxyprogesterone acetate has more side effects, 67.5% compared to cabergoline. The most common side effect is medroxyprogesterone acetate group was amenorrhea, whereas in cabergoline group, the nausea and vomiting is reported up to the 45% of the patients. So the conclusion of this study that the cabergoline and this medroxyprogesterone acetate, because once the patient of endometriosis are coming to us, yes, of course, the pain relief is a very, very common symptom. So the study has concluded that both of these drugs are equally effective in decreasing the chronic pelvic pain due to endometriosis, but due to lesser side effects and less frequent dosing, the cabergoline has a better acceptance than medroxyprogesterone acetate. So it can be used as an alternative for this medroxyprogesterone acetate also too. So as we have just discussed, with this cabergoline, the main side effect has been the nausea and vomiting has been this is reported. This is another study has also been reported in Human Reproduction Journal also. They also concluded the same studies. I think slide is hanged. Slide is hanged. Just a second, I will. It is hanged. Meanwhile, if you are having any questions, please do write in the chat box. It is hanged. I am just connecting.
Mr. Amit, can we solve this problem? Mr. Kishore?
Yes, madam. Yes.
Amitji, I'm again downloading. Just from the download, I want.
Okay, madam.
Or
Okay. Yeah.
Meanwhile, friends, if you are having any questions related to this, please do write in the chat box. Huh? Is my slides are visible now?
No, madam.
No?
No. Kishore sir.
Backup slide are not visible.
Uh,
So kindly say you have to share it again, madam.
yes,
Kindly
yes,
share it.
I'm sharing. I'm sharing. I already shared. I don't know why it is not
It's loading. It's loading. It's loading.
It's loading?
Yeah.
It's loading, they are saying.
I think if it was paused, kindly stop share again. Share it, madam.
I will stop sharing.
Yeah. No. Yeah, we can see now.
Started.
You can see now?
Yes, ma'am.
Yeah, we can see.
Yes, visible.
I will make
madam.
it full screen. I will make it full screen. It's hanged actually. Give it to me. It's again hanged.
It's working, madam.
It's again hanged, Dr. Raki. So sorry. Some technical glitches are on.
Yeah.
Yes, it's connected. Yeah. It's done. I am sharing, huh? Yeah.
Okay. Yes, it's visible, madam, now.
Yes, visible.
Yes. Little bit up. Little bit up. One more up. One more up. Wait. This I have already shown.
Yes.
This I have already shown, so I will go. Sorry, friends, for this technical glitches. I don't know why it is not moving. Yeah, it's moving. Yeah, I have already. Yeah. So only last few slides are there. There is one interesting study in the February 2020 by Taylor and Francis. They again give the support that the potential role of the cabergoline to target neoangiogenesis in the endometriosis. The study has highlighted the role of cabergoline to target neoangiogenesis. So, a study have shown the exposure of cabergoline was associated with decreased number of active lesions, low cellularity, and significantly less developed vascularization. The study have concluded the stimulation of the cabergoline was associated with reduced phosphorylation to VEGFR2 to reduce gene and protein expression of VEGF, and to increase level of the anti-angiogenic markers. The study have shown the limitation of the currently available hormonal therapies and surgeries, the extensive clinical application of hormonal therapies and the evidence supporting their efficacy is still limited. While with some patients have got a good improvement with the use of this. Again, the study has been supported by this PubMed journal regarding the use of the Cabergoline for the endometriosis. This is again a recent study. So to concluding, the studies have suggest the dopamine and its agonist, the Cabergoline, promotes the VEGF receptor 2 and endocytosis, as we have just discussed. Targeting the vascular endothelial growth factor, VEGF, leads to an inhibition of endometriosis. So this one more study has been presented that what to use, whether this Cabergoline or this LHRH agonist. This study has been reported. They have done a study on the 71 patients with which this Cabergoline twice weekly for 13 weeks in the 46 patients. While other patients, they have used this LHRH. So these studies have reported that in this, the reduction of 64.7% with the favor of this Cabergoline, while with this LHRH is 21.7. So the studies have shown it yields a better results in decreasing the size of the endometrioma compared to this LHRH agonist by exerting anti-angiogenic effects through vascular endothelial growth factor receptor 2 inactivation. So no major side effects has been reported with this. So here we can see that again one more study for this comparison of this more express pain syndrome reduction resulting from 6 months from long Cabergoline administration either with GnRH analog or with Dynogest 2mg compared to a standard hormone therapy. So here you can see the percentage of the pain relief of the symptoms is significantly high in the Cabergoline with GnRH agonist. You can see 87.5%, and while with this this Cabergoline with Dynogest 82.2, with GnRH analog 78, with Dynogest 73, and with this Cabergoline alone is 65. So combination therapy. Again, this has been reported. You can see also this Journal of Gynecological Endocrinology in 2020 in the volume 36. This all studies has been reported. So the conclusion of the study that it yields a better results by decreasing the size of the endometrioma compared to LHRH and by exerting anti-angiogenic effects to VEGFR inactivation, no major side effects, easier to administer, cheaper than LHRH agonist, reduces the pelvic pain, can be tried as a first-line medical therapy before restoring this laparoscopic excision. So thank you to all of you for the patient hearing. Just
Thank you very much, ma'am. It was indeed a very enlightening lecture.
Thank you, Dr. Swapna. Thank you so much.
Now I request Dr. Vasudha Raju, ma'am.
Yeah. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. Yeah. Now I request Dr. Krishna Mandade to present his presentation. He is a young gem of Latur OBGYN Society as laparoscopic surgeon. Pardon? Are you able to hear?
We can hear you, madam. But
Yes, ma'am. Yes, ma'am.
Am I audible to all?
Madam, we will like to thank Ritu Santwani madam by giving e-certificate.
Okay.
Yeah. Madam, is it visible?
Yes, visible.
Please accept, madam.
Thank you so much.
Appreciation.
Yeah.
Thank you, madam. It was an excellent presentation.
Thank you, Dr. Aki. So before I wind off, so thank you once again, the Latur Society, for inviting me. Thanks to Amit ji and Manoj too. They both are my dear friends. And friends, I am having 5 academic groups. I think most of the Latur members society are in my academic groups. Those who are not and those who are interested for the constant this academic discussions, I am just dropping my number on the chat box. Those all of you are interested, please send me the WhatsApp message with your name and the workplace. I definitely add you in the academic groups. All are welcome for this academic discussions because I believe in one motto that knowledge is always increases by sharing. Thank you once again.
Thank you, madam. Thank
Yeah.
you. Okay, Rakhi.
Thank you. Yes, ma'am. I will show. Yeah. Now
Jati
we,
madam will continue with the CV of Dr. Krishna.
Yes, Dr. Krishna is a young gem of Latur OBGY Society's laparoscopic surgeon. He is associate professor at MIMSR Medical College, Latur. He is a consultant laparoscopic surgeon at Mandade Women's Hospital and Pravra Medical College. He is consultant and freelancer in laparoscopic surgery in Latur. He has published over 10 international papers. His special interests are in advanced endoscopy. Over the period, he has done 500 advanced cases of grade 4 endometriosis, radical hysterectomy, sling surgery, VVF repair, and complicated hysterectomy. We all are well versed with this surgery, so let us hear from him now.
Thank you so much, ma'am. Am I audible to all?
Yeah.
Yeah, thank you. Can I share my screen?
Please, sir. Please go ahead.
First of all, I'm thankful to all my elogious team, my president, my secretary, Raki ma'am, and all the elogious members who have supporting me for the surgeries in Latur. So now, without wasting much time, we are going to start with the laparoscopic perspective of endometriosis. So up till now, we have seen the diagnosis. Up till now, we have seen the medical management at the most for the endometriosis. Endometriosis is such a topic that we all know is difficult to understand as well as difficult to treat because we don't know the cause as well as the exact management for endometriosis. So why laparoscopy? Since the laparoscopy has arrived in the era, we are able to see the structures, we are able to see the disease by our eyes. That is the best advantage laparoscopy is going to give us. So for imaging modalities perspective, ultrasound, MRI has given us a lot of imaging confidence over the endometriosis. But still there is some lacunae, there is some limitations for the imaging thing for the endometriosis that we are going to overcome with the laparoscopy. So laparoscopy, why it is essential in endometriosis that we are going to see. So what we want to do is an exact diagnosis, extent of the diagnosis and severity of the disease. Although with a good ultrasound as well as MRI, we are able to diagnose the extent of the disease, but at multiple sites, the extent as well as the depth of invasion of the disease is still carried out best diagnosed by the laparoscopy. So it should not be performed within 3 months of a hormonal therapy because we don't want to underdiagnose the endometriosis, specifically if we are based on the diagnosis. So we need a methodical approach for the endometriosis per se. So what method of approach we are going to harbor in the endometriosis is a thorough inspection of the pelvis as well as the abdominal cavity, because the inspection is the only thing which will give us the idea about the location as well as extent of the disease. So each and every organ is affected by the endometriosis that we know, along with the abdominal cavity, pelvis, lateral pelvic walls, everything, every ligament, every peritoneum, every organ like bowels and retroperitoneal organs are also involved in endometriosis. So that we need a methodical approach while we go for endometriosis or while we go for a laparoscopy for diagnostic as well as an eradicative procedure. So we need to have a good vision while we are seeing the case of endometriosis. So there are few things like uterine manipulation helps in delineating the POD and rectovaginal septums. Then we need to have a photography or video recording. Then a generalized strategy to follow a minimum invasive surgery in endometriosis that we have to follow the laparoscopy, or we have to do a laparoscopy at most of extent in endometriosis, because in lot of continents in the world, more than 90% of the people are doing a laparoscopy so that they can eradicate or excise the tissue very well by any means, either by a sharp dissection or by a cauterization. So incidence of bowel infiltration, ureteric infiltration, and the infiltration of the rectovaginal pouches, the vaginal involvement is much more higher in endometriosis that we know. So we have to strategize to see each and every organ, whether it is uterus or apart from the gynecology, it can be even the major vessels, it can aorta, it can be upper abdominal structures. We have to explore and assess the disease very well. So for that particular reason, to assess or to diagnose it by a laparoscopy, we have to have a good hand as well as good friend circle, or we have to have a multidisciplinary approach to treat this kind of cases. So we have to mobilize the bowel. We have to learn to dissect the retroperitoneum. We have to be more conservative towards the excision rather than ablation. We have to do a sharp dissection whenever it is possible, and we have to use less and less cautery as far as possible. So appropriate counseling is must in endometriosis. Why we are saying this is because endometriosis is the least understood disease amongst the patients, because whenever it is coming towards the ovarian cyst or a hysterectomy perspective, or it is coming towards the cancers, it is well understood among the patient that the need of surgery is what. But in endometriosis, they don't exactly know about what is the need of surgery. So appropriate counseling regarding the extensive disease should be done to the patient. So we have to have a good pre-operative preparation apart from other gynecological laparoscopic procedures for the endometriosis, because we need to operate deep down to the maybe bladder or bowel or the ureters. So that is why we have to have a good preoperative preparation in terms of ureteric stenting, bowel preparations, and the drain and everything. So we have to have a good surgical trained team. We have to expose the structures not to be removed. We have to keep the important structures in view all the time, as we always say about the ureters, that we have to keep the eye on ureters. It's the way into the pelvis and how much it is involved and how less we can injure it. So carefully devascularizing the structures to be removed is a mainstay. Then coming to the surgery for endometriosis, the entire purpose of doing a surgery in endometriosis is restoration of normal anatomy in terms of preserving the fertility or enhancing the fertility. And apart from that, where the fertility is not the question, we have to have a radical excision for restoration of the function. So surgical objectives, as we know, there are a lot of consensus about the management of endometriosis in terms of surgery. Again, around the world, there are a lot of people who don't believe in doing a surgery in endometriosis, except there is a pain, there is a fertility issue, and there is restoration of function, as well as the bleeding and chronic pelvic pains. So extensive pelvic endometriosis, if we simplify the definition of extensive pelvic endometriosis, we have to have eye on very few things, like ovaries when it is cystic, when it is having chocolate cyst, when the ovaries are adherent to the posterior uterine wall, or in the POD, POD is completely obliterated, bowel involvement is there, bladder involvement is there, there is a hematuria or ureteric involvement in terms of strictures or a hydroureter and hydronephrosis, along with the distorted anatomy all over the abdomen as well as pelvis. So this is the first man, Rocketansi, who has identified the endometriosis in 1860. By that time, since today, we have come a long way to diagnose as well as treat in terms of medical or surgical management. So we have very good guidelines of different societies, American, Austrian, urology, and a lot of societies have given the guidelines about the management of endometriosis per se. So infertile woman with a ovarian endometrioma, this is the major issue to manage as far as the fertility is concerned. So few things we have to follow according to the guideline are excision of endometrioma capsule instead of only drainage and coagulation of the endometrioma wall. That should be avoided. We have to have a complete excision of the endometriotic wall to increase the spontaneous pregnancy rate. So coagulation or laser vaporization of endometrioma without excision of the pseudocapsule is significantly associated with increased risk of recurrence. So that if we want to avoid the recurrence, we have to completely excise the tissue. We have to counsel the woman regarding the risk of reduced ovarian function after the surgery and possible loss of the ovary also. So proper skillful surgical workup is needed in a first endometriosis surgery because we want to avoid a repeat surgery in endometriosis. Whatever we are going to operate, we should operate it finally. So operative laparoscopy in terms of excision and ablation, including adhesiolysis, rather than only diagnostic laparoscopy, should be performed to increase the pregnancy rates. So we have to consider the recent advances like CO2 laser and laser vaporization instead of a monopolar electrocoagulation, since it is associated with higher pregnancy rates. So it is therefore important not to delay the treatment because progression of the endometriosis may cause the problems with the pregnancy. However, in many cases, endometriosis damages and distorts the anatomy of the reproductive organs. This includes the scarring, blockage of the tubes, and lot of things. The presence of ovarian endometrioma itself reduces the AMH as well as the ovarian reserve. Damage may be permanent when the cysts have grown too large, so we may have to sacrifice the ovaries also. The chances of getting pregnant relies on the severity of the disease. As the disease is more severe, more infiltrating, than the pregnancy rates are obviously less. So types of operation currently we have in endometriosis is just a conservative as well as excision type or a complete radical excision type. So coagulation, which is avoided, we have to excise the endometriotic implants as far as possible. We have to excise the endometriotic cyst wall, excise the adhesions. We have to restore the anatomy, excision of deep infiltrating endometriotic nodules, excision of rectosigmoid and bowel endometriosis, removal of one of the more ovaries. We may have to sacrifice the ovary. We may have to sacrifice the uterus, removal of endometriosis of the bladder, laparoscopic uterosacral nerve ablation, which is not having that great results or not accepted worldwide. So this is a trending grade of endometriosis, depending upon the depth of invasion of the tissue, which we calculate theoretically what is the score and what is the depth of invasion. So sites involved, as we know, most common site involved is ovaries because of close proximity to the fallopian tubes. Then the commonest site is the POD because of shedding of endometrium is happening into the POD. That's why the second most common site is POD as well as the uterosacrals. Then coming to the broad ligaments, then bladder, then rectum, maybe it has gone up to the diaphragm also. So endometriotic lesions, variable appearance that we have to see whenever we are doing a laparoscopy, we have to follow the lesions, how they are appearing. Any lesion which is appearing apart from normal should be considered as an endometriotic patch, because there is lot of various what we can say display pictures of the endometriosis. There can be red lesions, there can be brown lesions, bluish puckered areas, there can be white plaques, there can be adhesions, flimsy areas, vascular areas, density of the tissue is more. So there are multiple superficial as well as deep typical lesions of endometriosis, as we can see in a laparoscopy very clearly. So these are the peculiar areas where we can see powder burn areas. We can see the endometrioma, where we can see the clear endometriotic pustules. We can see the fibrotic areas also, puckered areas also. So these are the few pictures of giving a clear-cut idea about the superficial endometriosis. So now we will go to the particular diagnosis thing, like how we can diagnose the there is some problem with the videos of hyperlink. Okay, so directly we can. Is my screen visible?
No, sir.
No, sir, not visible, sir.
I have started my video.
No, you have to share it again.
Yeah,
So,
okay.
share and select your video and share, sir.
Basically, I'm video is in the video player actually.
Yes, sir. So kindly share screen. Just click
Yeah.
on share screen. Then application window will pop up. In that, select your video and share.
Okay. Is it is it
Yeah.
shared now?
No, no, yeah, I can see your videos. Yeah, please play.
Okay. Now is it
Yes,
visible?
visible.
So this is a simple
Yes, sir,
video of
visible.
showing the restoration of anatomy, how we are going to restore the anatomy. So this is a simple video of a chocolate cyst, and we can see the ovaries are completely puckered and has gone beyond the uterosacrals and the posterior peritoneum as well. So this kind of picture, what we see usually in infertile women, at this particular point, we have to be very particular about the restoration of anatomy and conservation of the ovaries. So we can see even the bowel is adherent to the posterior uterine wall. So for these particular instances, we have to be very particular about a sharp cutting. We don't use a cautery, as well as we don't ablate the area as far as possible. We have to just restore the anatomy. We have to see the cyst areas or cyst walls are completely removed. And if the cyst walls are completely removed, chances of recurrence are less. Then again, we have to go for the ART cycles. That is the reality. Obviously, we have to go by. So for diagnosis purpose, we can see this video. We are able to see the shedding or dissemination of the endometrium everywhere in the peritoneal cavity. We are able to see on the POD. Fortunately, this is all superficial things we are seeing. There is no deep infiltrating endometriosis, but we can see very well how the endometrium is shedding in the peritoneal cavity. Now coming to the ovarian endometrioma, as we see, this is the commonest picture we see in endometriosis. So for preserving this fertility, we have to be very peculiar about the drainage of the cyst. Again, washing the cyst over and over again, and identifying the cyst wall with the proper planes. Even if with a lot of skill and concentration, we have to many times sacrifice the part of the ovary, or we have to sacrifice the tissue along with the ovary. But we have to try as far as possible. We have to restore the anatomy. We have to be blunt and sharp as far as possible. And we have to locate the ureter. We have to see where the ureter is going, where the ureter or retroperitoneal structures are involved or not, because we are pulling over and we are playing around the infundibulum pelvis. We are restoring the anatomy. At any instance, we can feel that there can be injury to the ureter, so that we have to have a constant eye on the organ like ureters, bowels, and bladder. So complete excision of the tissue is always required, and that is the must requirement for operating endometriosis laparoscopically. As we can see, we are using a sharp dissection. The brown patchy areas of blood, we are dissecting out. We are enucleating the sac. The complete excision of the cyst is required. So as far as the fertility is concerned, we have to be very peculiar about the conservative surgery. We don't have to cut much over the normal ovarian tissue. We have to focus on the brown areas. Even if you don't see the sac nicely, the delineation of the chocolate cyst is not great, then we have to focus on the stained areas of the peritoneum or the ovarian tissue, where we can dissect and we can remove the sac. So these are the simple ovarian endometrioma we can see. Then coming to the types of endometrial patches that we can see. So this is a very peculiar video which I got from my friend. This video is suggestive of a different kind of endometriotic patches, how we see and how we differentiate. So you can see the fibrotic areas. We can see the adhesions, flimsy adhesions. Behind that, there is a serosanguinous fluid. This fluid is also indicative of endometriosis. Then chocolate cysts that we know everywhere. Endometriosis, that means a chocolate, that we have to always remember. Then these are the powder burn areas over the anterior aspect. Then we can also see nodule on the uterosacral. Then we can see a nodule on the round ligament as well, that we have to dissect very nicely. So this is a endometriotic puckering or the fibrosis we can see on the uterosacrals, as well as the hypervascularity, and we can see the endometriotic scarring on the anterior abdominal wall or the anterior peritoneum. We can see the bowel involvement, endometriotic picture, pitachi, hemorrhage. We can see the flimsy adhesion. So these all presentations, this is a vaginal endometriosis we can see. These all presentations are likely when we do a laparoscopy, and whenever we are doing a laparoscopy, we should not just come by diagnosing it. We have to remove these areas and we have to excise these portions so that patient can have relief of the pain. So we can see the endometriosis of tube as well as the left cornu. So in these kind of presentations, we may have to sacrifice the tube. We can see the superficial ovarian endometriomas or endometriotic patches also. And this is the endometrioma of the left ovary. Then again, we have to drain it, we have to irrigate it, we have to remove all the patches. So this is a typical presentation of endometriosis of a different variety, like how much variety or how much type of patches we can get in endometriosis. So this is the endometriosis of scar also, cesarean section scar. Nowadays it has become common also, cesarean section scar endometriosis. We have to completely excise this scar also. Then coming to the CO2 laser ablations. Now, this is a beautiful video. I brought it from online itself. This is a video which suggests that we have to be how minimum invasive or how less and less destruction we have to carry, because CO2 laser has got a perfect depth what we want. We are going to have the perfect delineation of the patch, and we have to remove the patch which is going to give us a trouble. So this is a video of a CO2 laser ablation or CO2 laser excision of an endometriotic patch. Then coming to deep infiltrating endometriosis. This is a particular about a role of laparoscopy is more dense in a deep infiltrating endometriosis, where we can see endometriosis all over the abdomen. So this is the endometriosis of the wall. We have to excise the endometriosis of the wall. Whenever we are excising the nodules, first of all, we should always keep in mind that we have to go from the virgin area. We have to dissect the areas where the endometriosis is not there, and we have to approach the area where endometriosis is infiltrating. So we have to see the ureters, whether they are involved or not. We have to remove the patch over the ureter. That means if the uterosacrals are involved, we have to expose the ureter till the Verdam's tunnel. So we have to see whether the involvement of the endometriotic nodule is extending from our area or not. And if it is extending from our area, we have to excise the entire area, expose the entire area. So this is a bowel endometriosis, you can see. So we have to remove the entire patch of the bowel. These kind of patient present to us with the lot of pain as well as the bleeding from the rectum and from the urine, a lot of pain which is not responding to the medical treatment is the commonest presentation of such kind of DIE nodules. So we have to be aggressive on this kind of disease. We have to have a good skill over the suturing as well as the radical excision as well as the retroperitoneal dissection. We have to have a good multidisciplinary approach. We have to be in touch with all our urologists, surgeons who can perform these kind of surgeries, and along with them, we have to do these surgeries by taking a high grade consent from the patient, so that patient should understand what else can be done or what else patient can have, like whenever we have to perform a stoma or we have to resect a lot of portion of the rectum. So appendicectomy is a quite simpler process that we know. Every gynecologist are well versed with the appendicectomy also. This is easier procedure to be carried out when endometriotic implants are quite normally seen on appendix also, because appendix is quite mobile organ. It is always descending into the pouch of Douglas, and we can see the endometriotic dissemination over the appendix also. So this is a ureteric endometriosis. We can see that there is a hydroureter, and hydronephrosis was also diagnosed on CT and MRI. We can see the stricture formation around the ureter. We have to cut the ureteric ends. We have to be very particular about the extent of the disease. There should not be a remnant of the disease, because such a extended surgery or such a deep surgery already we are doing. We should not end up in incomplete surgery per se. So suturing a ureter or excising a ureter or bladder is not that difficult surgery, because we are already well versed with the tubal anastomosis and the bladder suturing. So we don't have to bother much about the ureteric suturing, because we have to suture it like our tubes only. The provided thing that we have to be prepared with the consent, as well as the implants of the ureter, as well as the ureteric stenting. So this is a simple tubal anastomosis that we can see, which is happening with the ureter. And at a particular point, when we have taken a 2-3 stitch over the ureter, we have to keep the stent, and we have to again recanalize the ureters, and stent can be kept for 21 days and it can be removed. So histopathological finding is definitely suggestive of endometriosis. So these are simple tubal anastomosis like things happening with the ureter. But at particular point, there can be a dense adhesions around the ureter. There can be a nodule involving the ureter as well as uterosacral. At that particular point, we may have to go and resect the ureter and implant with the Boris flap also. So bladder endometriosis, this is typically found thing whenever patient is presenting post-cesarean section endometriosis, or the endometriosis which is involving or which is presenting with the blood in the urine as well as pain. So the most important thing is to excise the nodule nicely. We don't have to bother about the sacrifice, how much bladder is going to sacrifice, how much tissue is going to sacrifice. So we have to completely excise the bladder tissue, maybe 1 or 2 centimeter here and there, but it doesn't matter as far as the bladder is concerned. Bladder is quite forgivable organ. We can suture it nicely in 1 or 2 layers. So we have to keep an eye on the normal tissue as well. We have to keep a traction on the endometriotic nodule as well. So whenever we see a normal margin of the bladder, that is the end point of the excision. So we have to excise the tissue nicely without bothering the bladder or the bladder musculature or the sacrifice of the how much bladder tissue we are sacrificing. So bladder suturing is, again, it is as simple as the wall suturing that we know. We can suture it in a single layer or multiple layer. So these kind of, so at the end we can see, we can do a cystoscopy also, and we can see whether the nodule is there or not. So this was a DIE. Then coming to laser ablation excision, that we have one video over laser ablation. We can see how beautifully a laser can remove or the excise that patch, because it is considered to be a preferred method of This is the type 2 endometrioma that we usually have the picture. We have to drain, we have to remove the cyst wall, we have to restore the anatomy. We can inject the vasopressin, we can put the interseed. There are a lot of things we can do for achieving the hemostasis as well. At many times, removing the endometrioma of type 1 is difficult than type 2 because of poor delineation of the endometrioma or the sac which is having there. Then recently we have operated this case of scar endometriosis. Someone has asked about the cesarean section scar endometriosis, how it looks. We can see area of vascularity around the scar, and we can see the area of vascularity around the bladder also. So in this particular case, this was a post-cesarean section case of 3 to 6 months. What we did is uterine artery at origin we ligated for the safety of the area to be on a safer side. So this is a simple procedure that everyone should understand before doing an extensive or the area. If the area is quite bloody or you want to dissect the area near the uterine arteries, it is better to ligate the uterines at the origin part. At the same thing we are doing on the left side too. We have ligated the uterine bilaterally at the origin site. And then we have started dissecting the bladder. You can see the bladder is being dissected. Along with the round ligament, there are adhesions because of the previous cesarean section. We can see the area of vascularity which is delineated from the scar side. This particular patient shows the hyperechoic areas on ultrasound as well as MRI with the discharging points. So the diagnosis nowadays has become very clear, as well as we can say it has become simpler than before because of the advancement of the TBS and MRI. So this is the area of the scar we are removing. We can see there is a lot of bleeding, though we have ligated the uterines. We are removing the scar area which was puckered along with the anterior pelvis as well as the area which was near to the bladder. So once we have removed the endometriotic patch or the endometriotic tissue, we have to be very radical. Don't bother about the tissue which we are removing. Even if we open the bladder, it doesn't matter for us. We have to excise the good area of vascularity around the excision of the nodule. Now the scar is already open that we can see. We have to suture the scar like we always do. Nothing much difficulty in the excising the scar as well as the suturing the scar. So this was a scar endometrioma. And after that, we have to irrigate the cavity thoroughly. Definitely, we have to see the other patches of endometriosis also. And achieving a hemostasis in endometriosis is also an important thing. We have to be very sure about the hemostasis because the recurrence is always there with the again bleeding points over the endometrioma. So once we are sure about the hemostasis, there is an interseed, that is a cellulose tissue protein, which we can put on the scar, and we can be sure about the adhesion barrier, that the again bowel and rest of the things should not adhere at that point. So that was the end of video presentation. Thank you so much. I hope everyone is alive.
Yes, sir, we were. A very interesting presentation, sir.
Thank you so much.
The videos were also excellent, sir. So we will have one more question. We have one question from Dr. Anuja Kulkarni, madam.
Yes, ma'am.
Madam is asking, would you recommend injecting vasopressin before endometriotic cyst excision?
Yes. We can do a vasopressin injection before excising the tissue, and we generally do it. But what happens if we have already cut the tissue or the chocolate cyst is already drained? At that time, it becomes a little bit messy and difficult to inject the vasopressin also. And whenever the cyst is open, the cyst wall automatically comes in our hand. If it is not, then we have to excise little bit of ovary and we have to pull out the ovary. We have to invert the ovary. Then we get the sac nicely. But if the endometrioma is very big, the wall of the ovary is very thick, at that particular time we can inject the vasopressin before dissecting it. Definitely we can do.
Yeah. Dr. Akhi? Dr. Akhi?
Now I request.
Yes, ma'am. Yeah.
Can you display the e-certificate
Certificate for Dr. Krishna.
Yeah, sure, ma'am. Yes.
Thank you, Dr. Krishna, for a very good presentation and nice videos. And here's your
Thank you.
e-certificate, Dr. Krishna.
We will be mailing you, sir, soon.
Okay, thank you, ma'am.
Thank you so much. Yeah.
Swapna and Prachi, you can take over.
We will be
Now I
moving.
hand over the session to Dr. Jaju madam for further proceedings.
Dr. Nilesh Valkavde is our next speaker. He is MS DNB and MNA MS. He is fellow in reproductive medicine. He is fellow of gynecology endoscopy. He has diploma in endoscopy also. He is clinical head and fertility specialist of Oasis Fertility Center, Pune. He is joint clinical secretary of Pune Obstetric Gynec Society. He is chairperson elect 21-23, quiz committee Foxy. He has many awards, gold medals at MS exams. He is winner of Foxy Dr. Usha Krishna quiz competition in 2009, West Zone, Nagpur. He has best debutant POGS Dr. Smita Zog Award of 214 to 215 by Pune Obstetric Gynec Society. He has best paper award also. He has many publications, national and international journals. He has edited many books. He has including souvenirs. He has 7 chapters which are contributed by him. He is editor of Foxy FOCSS. Over to Nilesh, sir.
Thank you, Balchandra madam. Thank you, President Latur Society, Dr. Gore madam, Secretary Dr. Rakhi madam, for inviting me for this today's session. And I'm seeing how smoothly the things are going on throughout this session. So hats off to your administration.
Thank you so much, sir. You sure, sir? Nilesh, sir, has been paused.
Yeah, it must be network issue from the doctor side.
Yeah.
Yeah. I'll call doctor.
Yeah.
With that shot, is my screen visible?
No, sir, no.
No, sir. You have to select your PPT and share again. Just share screen. Kindly unmute, sir. Kindly unmute. Yeah, it's loaded. Yeah, we can see your PPT.
Okay, thank you.
Yes, sir.
Yeah. So today's topic is stimulation protocols in endometriosis and role of probiotics, if any, in management of infertility patients. So all we have seen since morning that endometriosis is an enigmatic disease. And I mean to say that endometriosis is also an invisible disease. And because of that, I have this short poem of an invisible woman who is suffering from pain associated with endometriosis. I am an invisible woman, not because people refuse to see me. They know I'm here, but it It's as if my pain detracts from my existence, and my presence too often is mistaken for my absence. I am an invisible woman. I think this is a story of an endometriosis woman who is suffering from that excruciating pain. Along with that, she has problems with infertility and so on. We all know that endometriosis is an enigmatic disease characterized by non-specific symptoms, non-specific biomarkers, lack of awareness of the disease, and the stigma associated with the diagnosis of endometriosis. I would now quickly take up an opinion poll from all the panelists and the delegate, and I would ask the technical support to launch the poll when I ask this question. What is the best pre-treatment for endometriosis, if any? Does anyone practice any pre-treatment before the patient goes in for artificial reproductive technologies, surgery, GnRH analog, Dynogest, or none of the above? Can we launch the poll, please? Yeah, thank you. The second question in the poll is, what is the best protocol which you are using for endometriosis in the patients of IVF, whether it is ultra short, long, or ultra long protocol? And the third question for all of you is, which is the best method of embryo transfer in endometriosis? Is it a fresh transfer, a frozen transfer, a down regulation followed by embryo transfer, or it depends upon the embryo quality? So wanted this to be an interactive session, and we all know that this is an enigmatic disease. So we could have the opinion of the august audience present here before we proceed in for the lecture on endometriosis. Technical team, if you have maximum people voting, we can close the poll. And
right now 25% voted, sir. 25% people voted.
Okay, so please quickly answer these questions so that we can go on to the opinion, what's the form by the august audience. Can we have the answers or the opinion of the results of the poll? Yeah, thank you. So the first question was, what is the best pre-treatment for endometriosis? Maximum people have answered as Dynogest. We'll see in the lecture how we evolve this opinion. We want to see how we are going to form our opinion regarding to this and what does evidence say. So I'll keep this answer that Dynogest many people think. And second option was GnRH analog. So we'll see which is the best pre-treatment or whether pre-treatment should be given or not. The second question was, what is the best treatment protocol for endometriosis? Maximum people have answered long agonist protocol, 47%, and short protocol, 41%. So close battle between that. So we'll see which is the protocol which is currently the standard protocol for endometriosis. And the third question is, which is the best method for embryo transfer in endometriosis? And many of them, many of the audience have answered it like down regulation followed by embryo transfer rather than a fresh or frozen transfer. So we'll see what is the best method. Thank you for participating in the poll, and we'll go ahead with the talk. So endometriosis and infertility, around 25 to 50% of infertile women have endometriosis, and 30 to 50% of endometriosis women are infertile. Many of the causes of unexplained infertility are mostly due to endometriosis, as our laparoscopic friends have suggested that we should put in the scope whenever we have doubt. Prevalence of endometriosis is 6 to 12 times higher in infertile women than in other category of patients. Why does endometriosis cause infertility? So endometriosis can cause problems at various levels, starting from the hypothalamo-pituitary ovarian axis. So we have the altered pituitary ovarian axis, altered LH surge. There can be problems with fertilization like oocyte link, reduced fertilization rate, poor spur binding capacity, reduced sperm motility. Pre-implantation embryo, there can be poor embryo quality or embryo arrest in cases of endometriosis. There can be implantation which can be at fault. So there can be reduced uterine receptivity or altered hormonal regulation. then there can be problems with the pregnancy as well. There are problems with the ovulation and the ovarian function as well, which we'll be highlighting in detail in the slides to come. So toxic pelvic cavity is what is noted in endometriosis. So the incidence of chronic endometritis is more than 40% in cases of endometriosis. Invasion cascade by toxic factors causes this inflammatory process. And we can see in the picture that many of these inflammatory mediators like the haptoglobulins, the matrix metalloproteinases, the interleukins, the prostaglandins are all increased in this pelvic cavity, and therefore we have what is called as a toxic pelvic cavity, which can cause problems with the folliculogenesis as well as problems with the endometrial receptivity. So these factors are going to affect both ways. So the endometrial receptivity in eutopic endometrium associated with endometriosis, why is it affected? So there is progesterone resistance which comes to effect because of inadequate antagonism of estrogen action, increased inflammation, inadequate differentiation of the stroma.
Mr. Kishore?
Yes, madam. I'm the same issue with the network. Network is fluctuating from doctor side.
Of the endometrium study.
Kindly change to presentation mode, sir. Full screen, then continue. Yeah, please.
Okay, thank you. Sorry for the technical problem. So there can be problems with the inflammatory markers. There can be a rise in the matrix metalloprotein, and all this causes problems with the oocyte quality. The endometriotic cyst itself can cause DNA mutations, altered angiogenesis, changes in the gene expression profile, changes in the hormonal receptivity. This hormone biosynthesis can be altered, and there can be high incidence of reactive oxygen species and oxidative stress along with the free iron radicals. Now, this is a mechanism where the cellular and molecular features of the endometriotic cyst, they cause a pathophysiology, altered pathophysiology in the ovarian cortex. And therefore, there is a loss of cortex-specific stroma. The smooth muscle cell metaplasia is there. Microvessel density is reduced. And follicular maturation is affected. Follicular density is affected. And in general, this is because of the increased oxidative stress and increased fibrosis. So when to offer AR, artificial reproductive technologies in endometriosis patients? So whenever it is grade 1, 2 endometriosis, but the tubo-ovarian relationships are not maintained, whenever we have failed 3 to 4 cycles of IUI, post-laparoscopy correction, if there are improved pregnancy rate, it's well and good. But if there is a long duration between the laparoscopy and there is no fertility after that, you can think of going for a ART. In cases of grade 3, 4 endometriosis cases, mostly the tubo-ovarian relationship is altered and not maintained, where IVF and ICSI can be a treatment of choice. 3 months of GnRH agonists have improved pregnancy rates irrespective of whether they're going for IVF or not. So what counseling we need to do whenever the patient is going for IVF in cases of endometriosis? So patient may need to go for multiple cycles of egg collection or embryo pooling, as what we say, because sometimes the reserve is less, sometimes the oocyte quality is poor. So in the first go, we may not be able to get the good quality. However, we will see what is the best protocol we are going to follow. But sometimes a change in the protocol can also help us. So therefore, egg or embryo pooling may be necessary. FET may be necessary in some kind of patients. Risk of cycle cancellation is very high. This counseling needs to be done whenever there is a grade 3, grade 4 endometriosis. Increased dosage of gonadotropins is going to be there. Therefore, the cycle cost is going to be high. Agonist or antagonist can be used, but long agonist protocol has yielded little bit better results. So this counseling again should be done. endometrioma need not be removed unless it is indicated, and we'll see later on what are the indications of removing endometrioma before we are going for IVF. Determinants of success in IVF needs to be discussed with the patient. So if it is a case of deep infiltrating endometriosis, if the age is high, if the AMH levels are low, and the number of attempts of IVF have already been exceeded more than 2 or 3, then the chances of success in IVF will drop down with all these parameters. If there is a history of recurrent endometriosis, if there is a history of surgery done previously and recurrence with pain associated, then the chances of failure will increase. So all these are determinants about success, and we should counsel the patient about it. So predictors of success also depend upon the therapy for endometriosis, AMH levels, progesterone levels. They also tell us about whether the success is going to be there or not. Now, what is the impact of endometrioma on our IVF and ICSI outcomes? So this counseling should also be there. So whenever there is an endometrioma, we all know, we have already seen that presence of endometrioma takes your grading to stage 3 or grade 3 endometriosis. So it becomes a severe endometriosis once you have diagnosed endometrioma. So there is no role of conservative line of management in such kind of patients. You need to go for aggressive treatment in the form of controlled ovarian hyperstimulation with IUI, or if it fails, directly go for IVF, or after IUI fails, you can go for IVF. So the impact of endometrioma on IVF and ICSI outcomes, this was a large systematic review and meta-analysis conducted by Hamdan et al. In 2015, which suggested that endometriosis may have similar reproductive outcomes whenever the disease is limited, whenever it is grade 1 to grade 3 disease. But the cycle cancellation in IVF was significantly higher in cases of these patients, especially deep infiltrating endometriosis and stage 3-4 endometriosis. Surgical treatment of endometrioma did not alter the outcome of IVF and ICSI. So therefore, pre-surgery before IVF or ICSI may not be indicated in each and every patient. The reduced ovarian reserve may be attributed to the presence of endometrioma per se. Again, this study also suggested that a higher dosage of FSH was required whenever ovarian stimulation was done in cases of endometrioma than in other population. A lower antral follicle count and indicating a lower reserve indicated a negative impact on the IVF or ICSI cycle, and there is an increased risk of cycle cancellation associated with IVF. So prediction of ovarian response in women with endometrioma undergoing IVF. So this was a study by Inal et al. Where 120 women with 60 with endometrioma and 60 with controls was seen, and antral follicles and oocytes retrieved were higher in the control group rather than in the endometrioma group. And this was associated with the AMH, correlated with the AMH levels also. Oocyte quality, we have already seen that oocyte quality is poor, so this study validates it. So there is a mounting evidence that the quality of oocytes retrieved through ART can be altered in cases of endometriosis. Effect of endometrioma cystectomy on the cytokines of follicular fluid and IVF outcomes was assessed. And it was shown that there was no significant difference in the cytokines or chemokine factors, even if when surgery was performed or not performed. So now before going in to the actual stimulation proper, we need to assess what is the role of endometriosis fertility index in prognosticating these patients of infertility. So endometriosis fertility index is divided into 10 points, and 5 of these points are related to the age, duration of infertility, and prior pregnancy, if any. If the age is less than 35, it's favorable. If infertility duration is less than 3 years, it is favorable. If there is a history of prior pregnancy, it is favorable. Now there is something called as the LF factor. We are going to see what is the LF factor. So if the higher the LF factor, the higher the score is going to be there and a more favorable outcome. Then this endometriosis fertility index also takes into account the American Fertility Society revised guidelines for the endometriosis. And if the lesion score is less than 16, it is favorable. And if the American Fertility Society total score is less than 71, again, it is favorable. So we'll see what is this score. So this laparoscopic assessment has to be done before we can give this score. So these revised American Society ASRM guidelines are used for this laparoscopic scoring, where stage 1 is score 1 to 5, stage 2 is 6 to 15, stage 3 is 16 to 40, and stage 4 is more than 40. I will not go into the details how you calculate this score because this is available everywhere. Now, what is important is the least function score, which is calculated at the conclusion of surgery. And this is again a little bit subjective matter, but yes, the fallopian tubes, the fimbria and the ovary are assessed on both the left and right side, and they are seen whether they have a normal architecture, whether there is a mild dysfunction, moderate dysfunction, severe dysfunction, or there is the function can be absent or non-functional. So this is very important to calculate the LF scoring at the end of surgery to give the patient the endometriosis fertility index. Now, how to calculate this LF scoring? It depends upon these parameters. I'm again not going into the details. So if the tube is damaged severely, you can have sulfingitis systemica nodosa or severe limitation in the motility of the tube, complete tubal obstruction or extensive fibrosis. Then there can be fimbrial damage, severe injury to the fimbria or extensive scarring of the fimbria. And there can be ovarian damage. There can be severe reduction in the size of ovary, large endometrioma, which is obliterating the ovary, injury to the ovarian cortical tissue, absent ovary or completely ovary which is completely encased in adhesions. So this will give you a clue that this is a non-functional ovary. And how does this prognosticate? Higher the EFI score, near 10, better the prognosis. So endometriosis fertility index was first developed in 2010 by Adamson and Pasta, which gave a score around 0 to 10, the first 5 points being the age, duration of infertility and history of pregnancy, and the rest being the ASRM scoring and the least fertility score, least function score. So how this is the conclusion of this total slide. If the EFI score is 6 to 10, then the patient can be advised natural conception for 2 years. So we can wait for such kind of patients. If the EFI score
Mr. Kishore, there's again some technical issue.
Yeah, ma'am. Some technical issues from doctor side itself. We lost the signal from doctors, ma'am.
Will you
Yeah.
call him?
Yeah, I'm calling, ma'am. Give me a second.
Well, we are really sorry because there's some technical issues. So kindly bear with us. We'll try to sort out the problem, or else we'll move on to panel discussion if the issue is not solved.
Yeah, ma'am. We're trying to reach out the doctor, ma'am, but some mobile also not reachable. I think some issues from network side.
Sir is online. Mr. Kishore, you can call him.
Sure, ma'am. Hello.
Yeah.
We really had good presentations from all the speakers, and I'm sure all of you have enjoyed this academic feast on endometriosis. It was an enigma, and your remaining questions will be sorted out in the panel discussions, and that is the highlight of this webinar. So after this lecture of Dr. Nilesh, we'll go over to the panel discussion.
Mr. Kishore, any feedback from sir?
Madam, continuously trying to doctor, but doctor phone also not reachable.
It's not reachable.
Yeah, must be from network issue from doctor side.
दुपारी कॉल केला गेलेला क्षेत्राच्या बाहेर आहे. कृपया थोड्या वेळाने प्रयत्न करा. The number you are calling is out.
I think should we start the panel discussion then without causing much delay? Dr. Aki?
It's currently.
The phone is saying busy, but we could not trace sir.
Okay, what we'll do, we'll start with the panel discussions. That is causing a delay.
Yeah.
You'll show sir's e-certificate and then we'll move over to panel discussion. Yeah, so this is the e-certificate for Dr. Nilesh Balkode. So because of the technical issues,
Sir has joined, madam. Sir has joined.
Sir has joined. Okay.
He's there.
I'm sorry, the internet had gone.
Sir, you can continue.
Thank you. So I was discussing about endometriosis fertility index, which is a very important tool, whether to continue for IVF or whether we need to start with a natural conception. Am I audible?
Yes, sir, you are audible.
Okay.
Your screens are also visible, sir.
Thank you. So there is a pre-treatment in endometriosis, which is very important. So one part of the pre-treatment before going in for stimulation in IVF is size reduction. Second part can be the use of antioxidants and treatment of poor ovarian reserve in cases of endometriosis. And third part can be the synchronization of the follicles. So the size reduction of endometrioma can be achieved by 3 different techniques. One is the surgical thing where we can operate the endometrioma. The second is the injectable therapy with GnRH analogs and add-back therapy. And the third is the newer oral agents, which already we have discussed, like the selective progesterone receptor modulators, Dinoges. We have the newer molecules like Cabergoline and Letrozole being used for endometriosis. So these can all be used for size reduction and optimization in endometriosis. So now, does size reduction helps? Does surgery help? So what are the pros and cons of doing or not doing the surgery before IVF? So already surgery part has been discussed, but we need to discuss whether we need to operate every patient before going for IVF. So the risks of surgery are what? The surgical bleeding, infection, visceral injury, impact to the ovarian reserve is a very important risk. Therefore, the preoperative and postoperative AMH levels are very important. The premature ovarian failure can be an important thing. Incomplete surgery can cause recurrence later on, and the surgical competency. And there can be a potential delay in starting treatment. So all these are the complications associated while doing the surgery. And if we don't do a surgery, then what are the complications? Then there can be accelerated progression of the disease, pregnancy-related complications, follicular fluid contamination, sometimes difficulty in the oocyte retrieval, and chemical peritonitis, risk of infection to the endometrioma while operating. So all this needs to be kept in mind. So what does the evidence say? To excise or not to excise? So there should not be a blanket approach for removal of endometrioma in each and every patient. Excision of endometrioma capsule instead of drainage and electrocoagulation is better. Whenever you are going for a endometrioma excision, we'll see which endometrioma to operate. Prior counseling and regarding the risk of reduced ovarian function has also to be made to the patient by assessing the operative antral follicle count and the post-operative AFC and the AMH levels, the decision to proceed surgery should be carefully considered in such women. What does the ESHRE guideline 2013 say? That in infertile woman with endometrioma larger than 3 centimeter, there is no evidence that cystectomy prior to ART will always help. In endometrioma larger than 3 centimeter, the GDG recommends clinicians to consider cystectomy to assisted reproductive technologies only when it is associated with pain or there is a accessibility of the follicles is at a problem. So only in these patients, the study group recommends surgery. The effect of surgical management of endometrioma on IVF and ICSI outcomes. So this was a systematic review and meta-analysis by Nichko and Emery et al. The surgery seemed to improve live birth rate, but the difference was not statistically significant. So as of now, there is no significant difference whether you operate or you don't operate. So depending upon, you should follow an individualized protocol. However, surgery has shown to diminish ovarian reserve definitely after endometrioma cystectomy versus the idiopathic diminished ovarian reserve. So endometriosis per se will also affect the endometriotic reserve, but surgery has shown to impact it greatly. And this is a study by Roston et al. Which showed that the group A where surgery was performed, the ovarian reserve was decreased much more. Now, this is a Cochrane analysis in 2010, which said that cystectomy was associated with decreased ovarian response to controlled ovarian hyperstimulation. And there was no effect on the reproductive outcomes whether you operate or we don't operate. So they had suggested further RCTs for evaluation of this. And as of now, surgery is not a must before each surgery. We have to individualize the surgical protocol only in those patients where we feel that there can be problems with the follicular fluid, the follicle aspiration, oocyte aspiration, and there is a huge cyst. Only in those patients where we anticipate problems with the cyst, we can go for a surgery. Now, regarding hormonal therapies as pre-treatment for infertility associated with endometriosis, so how are we going to optimize the stimulation is by giving good hormonal therapies as well. So oral contraceptive pills, progesterones in the form of medroxyprogesterone acetate or Dynogest newer molecule, then the levonorgestrel intrauterine device system, antiprogestrogens, and GnRH agonist forms an important part of hormonal therapy for treating endometriosis. But in infertile women with endometriosis, it's this large study by Hughes et al. In 2007, which was taken up by the ESHRE as the reference landmark, has shown that surgery clinicians should not prescribe the hormonal treatment before surgery or after surgery. Now, this is a study regarding pre-treatment with Dynogest. So it is a molecule which can be used instead of GnRH analogs. So Dynogest has an anti-inflammatory and anti-angiogenic activity, and therefore it can theoretically improve the lesions of endometriosis. It can reduce the lesions. What impact does it have on the IVF outcomes? It is said that pre-treatment with Dynogest can improve the outcome.
Can you hear us, sir?
Sir, it's not audible.
Yeah. Yes, please.
Is there?
Yeah, doctor connected only, but
Hello.
Can I continue?
Yes, sir. Yes, please.
Sorry for the technical problem. So yeah. So in general, our hormonal therapy is effective as adjuvant to surgery before we go for ART. So ASHRAE guidelines clearly say that there is no role of hormonal therapy before or after surgery to improve spontaneous pregnancies per se, or even in cases of artificial reproductive techniques, we need not use hormonal therapy as a treatment for as an adjuvant to surgery whenever we are going for IVF. Regarding pre-treatments with antioxidants. So we all know that oxidative stress and role of antioxidants in endometriosis per se. So oxidative stress and the free oxide radicals, the reactive oxygen species and iron radicals have shown to increase the severity of endometriosis. So there are various lines of evidence which support the role of oxidative stress in development and progression of endometriosis. So theoretically, a role of use of antioxidants will definitely help in endometriosis treatment whenever we are dealing with the infertility. So this has been shown in different studies and animal models. However, this has not been validated in other studies, but we can see that all these free radicals and the lymphokines, the rantes, the interleukin-6, the matrix metalloproteinases, all these levels are significantly decreased whenever we are giving antioxidant therapy to patients. So this antioxidant therapy will reduce the inflammatory mediators and improve the effect or success of IVF. Regarding decreased ovarian reserve in patients of endometriosis, we can use androgens like the DHEA androgens and pre-treatment with growth hormone, where we find that the ovarian reserve is gone down in cases of endometriosis. Regarding follicular synchronization, we have follicle pool which is going to be affected, the quality affected. So therefore, we want a good synchronization. So therefore, if the reserve is less and if the follicles are not synchronized, we can think of starting estrogen 10 days prior with a 1-day washout before we start the stimulations with gonadotropin, or we can have synchronizations with the oral contraceptive pills with a 5-day washout period, but the dose required for gonadotropins is higher with OC pills. We can also use follicular antag for 5 to 7 days before we start actual stimulation. So if the patient comes to us on day 2, we start with the follicular antag for around 5 to 7 days and then start the gonadotropin or with the last dose of antagonist given. And then later on, whenever we are using antag for down regulation of LH, that also we are going to give it as a random protocol. So what is the right protocol we need to choose in endometriosis after discussing all this, the pre-treatment part of endometriosis, which I think is very, very important when we are going for endometriosis, is whether to go for a minimal stimulation, whether to go for an antagonist protocol or a long agonist protocol. So which is the right protocol? So we have different kinds of protocols in our kitty. We have the standard antagonist protocol, which we are now using maximally. Then we have the long agonist protocol. We have the ultra long protocol. We have the random start protocol if the patient wants to go for surgery immediately. We have the dual stimulation or the mild stimulation protocol where the first protocol has already failed or where the ovarian reserve is quite less. So we all know that the long agonist protocol, we give the agonist from the day 21 of the previous cycle, and daily injections of leupride 1 milligram per day are given to such patients till we start the stimulation. And on day 1, 2 or day 1 or 2 of the cycle, we assess whether the patient is down regulated and then start with gonadotropins. We continue with the agonist and the gonadotropins till we have trigger with the HCG. And this is how we can use the long agonist protocol. The antagonist protocol is where we start on cycle day 2 with gonadotropins, and we start with the gonadotropins either HMG or FSH and continue stimulation. Then we have the fixed protocol where we use the antagonist cetrorelix or ganirelix on fixed protocol, which is on day 6, or we use it as a flexible protocol whenever the follicle size is more than 40 millimeters. We can start the antagonist as a flexible protocol. Then we have something called as the ultra short flare protocol, where we start the agonist not too early on the day 21 of the cycle. We start it just on the day 2 of cycle, and on day 3 we start with the gonadotropins. So this initial slight flare effect of the agonist is taken, is used here, and this is also called as the agonist antagonist protocol, where we give agonist in a very small dose of around 50 micrograms of and decapeptyl, and this has to be supplemented. So we are just utilizing the flare effect here, and therefore for down regulation of LH we need to give antagonist again. So this is the ultra short flare protocol. So which is the right protocol you would choose for IVF? So ultra long protocol is down regulation for 3 to 6 months with
Kishore sir,
Yeah, ma'am.
again the sir is facing technical problem.
Yeah. I'm trying to reach him. Yeah, we lost the signal, ma'am.
Is sir there?
Can I continue, or is the time up?
Sir, you can
Yeah, sir.
continue
Please,
sir, in a short.
Last 5
Yeah.
minutes I'll take. I'm
Yes,
sorry
sir.
again for the technical problems. I don't know. Suddenly it is logging out of the system. So we have all these protocols, and if we see that IVF protocols in endometriosis patients, the debate continues for the best protocol. So we'll just see that agonist and antagonist protocols, whenever they were compared, we can see that the agonist protocol gives more oocyte yield, more blastocyst, and therefore this was shown to be the best effective protocol. And this was the era of Salam et al. So we'll go just by the era, and we will see here that there was an era of Salam et al. Way back in 2006. This large study in Cochrane database came regarding the ideal protocol for endometriosis. And this study, it was shown by Salam et al. That long-term pituitary downregulation for IVF cycles improved the success rate. Then came the era of Giorgio, which in around the later half of this second decade of the 21st century, which showed that the GnRH agonist and the antagonist protocols are equally effective to improve the fertility outcomes in IVF patients. So this was the second line of thought where we all shifted to use the antagonist protocol. Now we are in the era of CAO, or where we have the CAO study, large study, which has reborn again the Salam et al. Protocol, but there is some difference in that we have to give 2 or 3 doses of GnRH agonist, and this is the ultra long protocol where we have to use, and they have specified it that we have to use this protocol only in grade 3 and 4 endometriosis during stimulation. So for grade 1 and 2, the consensus is not there to use any protocol, but this Kao et al. Protocol shares that ultra long protocol could improve the clinical pregnancy rates in the randomized control trials, especially in stages 3 and 4 of endometriosis. And we can also see that AMH dependent protocol decision can also be made. So the controlled ovarian stimulation protocol can also be on the AMH dependency. Here we can see in the picture that if the AMH levels are less than 1.1 and if the AMH levels are more than 2.8, these extremes of AMH, we have the antagonist protocol which yielded the more embryo quality, more number of embryos than the agonist protocol. However, the number of oocytes were more in the less AMH group. However, when the AMH was between 1.1 to 2.7, that is the normal group where the reserve was not less or not hyper responders. In these kind of patients, we have seen that the long agonist protocol has yielded significantly higher success rates with respect to the pregnancy. So this is about the current consensus. We have some difficulties during this ovarian stimulation. We can have failure of stimulation, inadequate response, or poor oocyte quality, which we have to fight with. But there can be patients can be also be worried about increasing the rate of endometriosis. But studies have shown that IVF treatment or hyperestrogenism during IVF doesn't increase the chances of increasing the endometriotic implants. What precautions we need to take during ovum pickup are antibiotic prophylaxis, avoiding puncture of the endometrioma. If there is accidental puncture, you don't keep on aspirating the endometriotic fluid. if there is accidental soiling of the pickup needle and the apparatus, the whole apparatus needs to be changed so that the oocyte yield is not affected. Regarding success rates in endometriosis, how to we have seen regarding the protocols, but success rate will also be affected by the frozen embryo transfer. So it has been shown that higher birth rate is there and higher clinical pregnancy rates are there whenever frozen embryo transfer with GnRH analog was used as compared to the fresh embryo transfer. So we have the answer of this poll which we had taken initially. There is something called as a sandwich therapy. So sometimes surgery may not be indicated in the first go, but if the endometrioma is large enough and if this inflammatory mediators in the endometrio are going to affect the implantation, then post pickup after forming the embryo in an order that we should not lose the ovarian reserve, we can go for surgery later on after the ovum pickup and then go for a down regulation with GnRH analog and then go for a frozen embryo transfer. This is called as a sandwich therapy, which can be effectively used in cases of endometriosis patients. So this is the trial which establishes the sandwich therapy, that medical and surgical treatment before embryo transfer improves the outcomes in women with abnormal endometrial BCL6 expression. Now this BCL6 expression is seen in a very high content in cases of severe endometriosis, and therefore medical and surgical therapy can help giving us the success. So above all, we need an individualized approach for patients of endometriosis. And we all know that the answer to this question, which we discussed, what is the ideal protocol, is what is given by for the stage 3 and 4 endometriosis. For stage 1 and 2, we have to follow the individualized protocol. But for stage 3 and 4, we have the GnRH agonist ultra long protocol, which is becoming favorable in multiple practitioners. And is hormone therapy an adjuvant to surgical therapy? The answer is there is no role of treatment with hormone therapy while treating these patients of infertility. In the end, to summarize, we have these French guidelines which summarizes whatever we have spoken till now. So the French guidelines suggest that the anti-gonadotrophic hormonal therapy is not recommended for patients going for IVF. After surgery in infertile women, the use of endometriosis fertility index is recommended to guide for the further plan of management of infertility patient. And in infertile women with endometriosis, presence of endometriosis appears to compromise IVF pregnancy, and number of oocytes retrieved will be reduced in patients with endometriosis. So the ovarian suppression with GnRH agonist or combined hormonal contraceptives may improve the success rates of IVF, and this establishes the Kao et al. Protocol of ultra long protocol. So I thank you for your patient hearing. Thank you so much.
Thank you so much, sir, for this informative session. Now I would like to request Rakhi Sada ma'am to display e-certificate of Dr. Nilesh Balkade, sir.
So kindly
Thank
accept
you.
from our side, sir.
Thank you, Rakhi ma'am.
Thank you, sir.
Now I request Dr. Vasudha Jaju ma'am to summarize the session concisely.
Yeah. First of all, I must thank all the faculties for sharing their experiences and knowledge. Dr. Kulkarni has made it very clear with the very clear sonography films that systematic approach is to be done, and especially for uterine mobility, anterior, posterior fornix, identification of torus, and looking for all the bladder, rectum, anus, etc. And then one thing is very clear, that ultrasonography is the first line of investigation. If you are planning for laparoscopic surgery, and to know the extent and the degree and staging of endometriosis, MRI is used. Then Dr. Ritu Santwani, you have given a very nice lecture on medical treatments, and that is a new topic, Cabergoline. So after hearing your lecture, we have got confidence of using Cabergoline in our practice for pain management. And I think as it reduces the angiogenesis, you can also use it pre-operative. And then Dr. Krishna Mandade, he has done very nice videos, clear videos, and he has
shown all the types of presentation in this, how the endometriosis is present, the chocolate cyst, powder spill appearance, etc. And then only one thing take home message he has given is try to excise the cyst as much as possible. Don't do cautery or ablation. He has given a very nice message and very good presentation. Thank you, Dr. Krishna. And now Dr. Balkavade, he has emphasized on, so we are now sure that we all will use antioxidants before starting the treatment, during the treatment. And also he has given the various protocols for IVF after in endometriotic cases, which will be very useful those who are practicing IVF for ovarian stimulation. And then he has clearly mentioned the pros and cons of surgery, what to do and what not to do. Thank you so much, Dr. Balkavade.
Thank you, ma'am. I thank Dr. Vasudha Jaju ma'am and Dr. Bhalchandra ma'am for chairing the session. I request Dr. Rakhi Sada ma'am to display e-certificates of Dr. Vasudha Jaju ma'am and Dr. Bhalchandra ma'am.
Thank you, madam.
Thank you, Rakhi.
Okay.
Thank you, and Swati.
Thank you, madam. Okay, Swapna.
Yeah, here we come to an end of session 1. What an academic feast it was. Now we shall begin with our second session of panel discussion on endometriosis, case-based discussion. For this, I would like to hand over the session to respected Gore ma'am for introduction of moderators.
Well, thank you very much, Swapna. Now, since we are in Latur and we are having all the panelists and the moderators from a long distance, this is the advantage of technology. And I'm really happy to start with this nice panel discussions and introduction of the moderators. We have two superb moderators with us. The first one is Dr. Ganpat Sawant sir. Sir is ex-head of the department and professor of Padma Shri D.Y. Patil Medical College, Navi Mumbai. He has done diploma in gynec endoscopy in Germany. Sir is also director of Noble Hospital and Noble Plus Ghatkopar Mumbai Hospital. He's a life member and committee member of various societies, and his special interest is gynecological endoscopy, and also he's a member of Family Planning Association of India. He's attached as an IVF specialist to Morpheus Indo-German Test to Baby Center. He's a faculty at Etikon Institute of Surgical Education, Mahim. He's attached to Kohinoor Hospital in Mumbai. He was also a past secretary of IMA MEBS by Mumbai, branch Mumbai, and past president of Ghatkopar Medical Association. Sir, as everyone knows, he's a great sir. He's liked by all. Our next moderator is our very own Laturkar, Dr. Kalyan Baramde sir, who has acclaimed not only well acclaimed in Latur, but also Maharashtra and national and international level. Dr. Baramde sir is director of Latur Fertility Center, Private Limited, Latur. He is a chairperson of Public Awareness Committee, FOXY. He is a treasurer of IAG, immediate past president of Latur Society. He was organizing secretary of Latur Society at Latur Society IAG Conference 2014. Then UIAG, first UIAG conference at Latur 2017. Also organized of Endo World Conference and convener of first Pride IAG conference, which was held in December 2020. So I hand over to the moderators for the introduction of the panelists and to carry on the panel discussion. Baramde sir and Sawant sir, you can take it.
Thank you, President Swati Madam. That was very nice of you to introduce us. We are really humbled because of that. But I must tell you, since morning, this program is going so nicely, flawlessly. And in each and every conference, in fact, we are worried about the time. When the time brings and we have to wash out or we have to be in hurry. Whereas here, no speaker was told to wind up or close the session. So it was all speakers, they enjoyed it, all delegates enjoyed it. Next is
Same liberty is given to you, sir. Don't worry.
no, you can now stop here after 1 hour because I think others BVs they might be waiting for them to become free. But of course, we'll continue as per your whatever you say. So that is one thing. Second thing is there was a pin drop silence, even though there was a disconnection in between. So that's another such a nice part. Everybody was stick to their guns and they wanted to listen to everybody. So it's a wonderful. Now next, let me introduce my panelist. And the first one is Harish Vagasia. Harish Vagasia, can I have his slide? But even if it's not there, I can say only one thing. Harish is Jadoo wala admi, and his fingers speaks for himself. The way he operates, the way he handles the tissue. I'm really not interested in his biodata. But friends, if you see, all of us, when we go off the line, our photo is seen, our BV's or wife's photo is seen. But if you saw his photo, there was a uterus with flower. Look at some different idea. So he was so much passionate about his work and uterus. He is a person, only those who do not know, I must tell you, he's trained in cardiovascular surgery for a couple of years. Then he trained in endoscopic surgery in Ahmedabad, Mayflower's hospital. And today he's fearless about vessels, about organs, about bowel, of everything. And the way he handles the tissue, you must see to believe it. Next person is Dr. Nagendra Sardesh Pandey. I hope he has joined, and he is also one of the pioneers in endoscopic endometriosis surgery. He is the one who started focusing on endometriosis surgery long time ago, and he's attached to most of the hospitals in Mumbai and all over the country. He's really passionate about the endometriotic surgeries and the radical surgeries. Next is Dr. Sandesh Kade. Sandesh Kade, in fact, one of the sessions we said he looks like a policeman, but he has so much love about the nerves. Friend, just imagine we are learning about endometriosis handling, removing the tissue in toto. Now he wants to fine tune all the surgeries by preserving the functions. So that is basically his job is to basically he can see the all nerve fibers, sympathetic, parasympathetic, somatic, all these nerves, and he not only wants to physically remove the organ but maintain the functions. And we are proud that this mandali सगळी विखुरलेली आहे all over the Maharashtra, and they are doing such a wonderful job. Next is goody boy. If I have liberty to say, Chikna boy is from Pune, and as against all the massive radical surgeons, he loves eggs, sperms. So along with endometriosis, he's very gentle with these gametes. So he has tremendous interest in IVF also. So while managing these cases, he will look after both aspects of it, surgery as well as conservative approaches. So welcome, Ashish. Mahendra, Mahendra was very busy and he was not contactable, but he has promised he will join us. And yes, he is one of the young, handsome boy from Pune. And not that all are not handsome, others are also equally handsome. But we were together in some places while training in Mumbai. So Mahendra, welcome. And recently you must have seen him in a lot of operative workshops. Welcome, Mahendra. Especially he does a lot of endoscopic sling surgeries and endometriosis surgeries. Finally, you are another big boss from Latur, Dr. Rajesh Darade. So Rajesh, I think you are the king of all. I mean, administration, social worker, operative cases, everything. I mean, you handle everything so efficiently. We are really proud of you. And finally, my co-moderator, Dr. Kalyan, in fact, I always feel future MLA or Khasdar, I don't know why it comes to my mind, but why others should take that lead? Why not our person should be in that chair and look after ourselves? Now, this is what I wanted to say. Let me share my screen and we go ahead with our panel discussion. Now, friends, this panel discussion was in my slide. There is no mention of the place because all these panelists, they are traveling. They have been invited for so many complicated cases and workshops. I call them as sort of omnipresent, and they are not localized, or they are not only concerned with only one city or one place. And that's why I have not put their names here. And that's what I thought I must go ahead. Now, coming to the main topic, this disease is so bad and this is so symptoms. But I can say from all the discussion, what I have heard is सांगताही येत नाही आणि सहनी होत नाही. So this is how the condition is and it's so bad. But I'm confident about all my panelists, not because they know all the answers, but they can face any question. So I request all of you to put a lot of questions in this chat box and this thing. So please be ready with questions. And one request to all the panelists is, please don't give theoretical answers. We have heard so much since morning. What we want is your practical tips, because person like me, who is an average person, when I'm operating, what should I do? What step I should stop? What next I should do, or keep it in mind, because not necessarily all the time it will be planned. There can be surprises. And from your experience, we can learn. So I invite Dr. Kalyan Barmade to take his first case, and he'll take you through the first case, and then I come back after finishing the first case. Dr. Kalyan.
Welcome all. Petochi sir, namaste. Sandesh, my teacher, Dr. Ashish, Nagendra, my batchmate, and Guruvari Ganpat Sawan sir and Darle sir. So first case is 29-year-old infertile women, married since 4 years, primary infertility, with increasing dysmenorrhea, diagnosed to have 6 centimeter left ovarian endometrioma. Husband count is normal. What is the choice of treatment? Dr. Ashish is going to start whether a medical or surgical line of treatment for her.
Thank you, Kalyan, for inviting. And it's always pleasure talking with you. 29 years old and she's married for 4 years. If the husband semen analysis is normal, I wanted to again wanted to know about her AMH. I wanted to know about her tubal patency. That is the one of the things that has to be taken into account, because all of us know, even if we operate or even if we do a medical line of treatment, the recurrence rate is much more on a higher side. So only the 4 years of marriage, I wanted to know the detail of the lady for further evaluation, whether we wanted to go for medical or surgical line of treatment.
So her AMH is 4 and her HHG is showing bilateral tubal patency, but she has increasing dysmenorrhea.
So rightly said by you, Kalyan, if she's saying increasing the dysmenorrhea, it is definitely for pain release. There is an indication and there is a definitely concern that this endometrioma is likely to cause this particular problem. So better to do a laparoscopy and do a cyst removal. Along with there is a implants. Then we can do the total peritoneal biopsy of the implants, and then do infertility treatment.
So are you going to repeat AMH after surgery? What is your view, Dr. Haresh?
Hi, Kalyan.
Yes, sir.
So my straight answer is surgery for this case, because she has 2 indications. Okay. The one indication is presence of ovarian cyst, which is 6 centimeter, and the second indication is she has pain. You have to have 2 indications to operate on any patient, not one. Okay. Let's not talk about infertility. Of course, it's a part and parcel of this disease. So infertility is going to get, much better when you treat this patient surgically. But for surgery, you need to have 2 indications. That's clear. After that, coming to an AMH, you have pre-operative AMH, which is quite good. Immediately post-operatively, I will not repeat her AMH for at least a month, because you've got to have a dip in the AMH temporarily, which can show corrective results after a couple of months. So if you want to do anything like an AMH or an evaluation, I would do it after about a couple of cycles, not immediately.
So that is a recent view that previously it was thought that AMH falls But now with the recent paper, it is shown that after 2 months, it can come back to the normal. That's very rightly taken up. Dr. Sandesh, what are the various laparoscopic techniques used to deal with this ovarian endometriomas? You talk a lot about sclerotherapy, cystectomy. What is your view about doing these surgeries? You have to unmute, Sandesh.
Okay.
Welcome, Mahendra.
There are a lot of options to treat an endometrioma. Of course, everybody's concern is to preserve her fertility. So we know with every surgery, there is going to be some normal ovarian tissue loss, and nobody can prevent it. There is no cleavage plane histologically proved between a cyst and the normal ovary. So some ovarian follicles are going to go. So we have to choose the best one. Now regarding when the AMH is 4, when it is unilateral and the patient is being operated for pain, I think the best option would be to do a cystectomy, because the recurrence chances are least and the pain factor taking care is best with the cystectomy rather than with any other modality. Sclerotherapy is only if it's a very large and AMH is low, and or if it is the recurrence. Only in those cases we prefer to do sclerotherapy, and we don't do any ablative lasers or anything for as of now. So my best technique would be to do a laparoscopic cystectomy and to take out the nodule, because ovarian are the culprit for DIE. So to relieve her of her pain, you have to take out the peritoneum involved or the uterosacrals, or if any other DIE nodule is there.
Very rightly says, careless removal of endometriomas or inadvertent removal of the normal ovarian cortex can lead to loss of follicles and fall in ovarian reserve. Very rightly said, Sandesh. So now my question is, what are your coagulation techniques after ovarian cystectomy? Dr. Mahendra Borse can take this. Dr. Mahendra, can you? Dr.
Yes,
Rajesh Darade can take.
Right. Hello.
Yes, Mahendra.
It should be as minimum as possible, actually. So I suggest like very pinpoint cauterization. First step is you can wait for some time, and most of the oozers or bleeders may stop on its own. But if you cannot do that or they don't stop, then underwater, under irrigation, you should coagulate the major ones. And that is the maximum you should do. You should not keep on poking the ovary. That is what I would suggest in those cases. Somebody may suggest like pressing the ovary or something, but we are not doing that thing actually.
Dr. Harish, what is your experience of using vasopressin in such large ovarian cystectomies?
I am using vasopressin diluted solution, like 1 unit per 10 ml, and such 10 ml maximum. So, per ovary, like such an ovary is, given half a unit of vasopressin. It gives a fantastic result if the ovary, has some volume, which is a normal volume. So in the ovarian cysts, which are smaller in size, if it is a large cyst and you try to inject them, generally you enter in the endometrioma. So I have not seen that, those large cysts, it helps. But it does help in a smaller endometrioma. Smaller endometrioma, like suppose you have tackled a 6 centimeter, 7 centimeter endometrioma, and the opposite ovary has a 3 centimeter or a borderline cyst, which some schools say to leave it alone, and some schools says to remove. I generally don't fit into the previous school. I generally try and remove all the cysts possible. So the smaller cyst, I prefer vasopressin. Larger cyst, I do not inject vasopressin.
So it has a dual advantages. One is hemostatic, and secondly, it causes hydrodissection. Am I right?
Yeah. If you are in a good plane, then only it causes hydrodissection. Hydrodissection is not a primary purpose.
Right.
It can happen in certain cases, but it's not a mandatory thing. Sometimes it can lead you in a wrong plane, because it's a pressure which can go into the stroma, and you can remove some stroma. So that is actually, I would say it's a caution. A surgeon has to, it's a disadvantage. A surgeon has to be very, very, cautious when he is using vasopressin, not only for the vasopressin side effects. Of course, the side effects will not occur with such a low dose what I recommended. I recommended 1 unit in 10 cc, and such only one unit, means only 10 cc maximum you have to use. So that's enough. We do not inject on the cyst.
Kalyan, I'll just make one comment here.
Yes, please, sir.
Harish, you say there's a proper plane and a small cyst you will use the vasopressin, whereas Dr. Kade said there is no proper plane because there is no proved proper plane. So can you elaborate both of you on that aspect? And one is you said you use a vasopressin small but not on large. I mean, why such? Because we common man will think larger the cyst, I want to use it more because more surface area. So I want to have more hemostasis and more dissection. So can you elaborate? Please.
I can clear it.
Yeah,
so if you have a larger cyst, basically to begin with, if you know the natural history of the cyst does not occur in the ovary. It occurs on the surface. And when it occurs on the surface or in the corpus luteum, which is there, with lots of blood supply, and there is an implant. So what happens is the ovary tries to curl. Ovary always curls itself inside, and then the external lesion then becomes internal. So there is always going to be a plane. Of course, it is difficult for the people to find out the plane. So I will not say that there is no plane. Like, for example, if you see a deep infiltrating endometriosis, we cannot say that there is no demarcation between the bowel and the vagina, but or a rectum and the vagina. There is always a demarcation. You can't find it out. So the difficulty is in the finding it out. There is always a plane. The plane gets much more less demarcated as the cyst age advances. Now coming to the larger and the smaller, the larger one, large cyst generally compresses the normal stroma and the tissue and stretches it. So when you try to inject, sir, mostly you will perforate the cyst and inject within the cyst. I'm not saying it is not recommended. So one has to be very precise. So when you said it's for the beginner, for beginner to inject on a smaller cyst is more possible. Again, we do not inject on the cyst surface. Previously, we used to do that, but we stopped doing it for the same reason that if the needle pricks, if the patient breathes, when the anesthetist either gives a bambu or ventilating, that time the patient moves and your needle can just go inside a millimeter and you are in the cyst. So to avoid this, we give on the meso-ovarium area. So when you give on a meso-ovarium area, it functions very well.
So many good points in the sense, no direct puncture. We should go in the pedicle or the meso-ovarium. And about the vasopressin, as you said, the dose which you use cannot cause problem. But I mean, there is somewhere, it may not be related to the dose, but some of the patients are sensitive to vasopressin. So not necessarily all the time the reactions are because of the dose, but sometimes patients can be sensitive to it.
Yes, possible. Yeah.
Hey, Nagendra, when are you going to use? Sandesh, yes, please.
Sandesh.
See, what I meant by there is no plane is there are three parts to a cyst. When you puncture the cyst, the outer surface of the ovary, that is the part A, which is the most adherent part, and there the normal tissue and the ovarian tissue is together.
Merges, yes.
There is no histological plane. You send all specimens of the best of the surgeons, the histologist will find follicles in that.
Correct.
I can just compare one thing. Sandesh, I'm sorry to interrupt you.
The part B and part C is as you go towards inside, as the cyst becomes bigger, it is just pushing. That is the part where it can separate. But the main part where it is fibrotic will have no, and that is where you lose. If you are losing follicles in part B and C, you better stop operating.
So it's like umbilicus in the abdominal wall, where all the layers are fused. Okay. So just like that, there is a punctum in the ovary where all the layers are fused. So I had a experience of staying with one surgeon called late Dr. Luca Minelli. He expired, sadly because of COVID last year, and he was in Verona. And he used to excise the entire rim, which Sandesh mentioned, which is a fused ring. And after that, rest of the area, he used to just do cystectomy. So this is one practical point which you can, if your plane is not there. So do not try and find out the plane exactly at the punctum area where everything is fused.
Just to make it simple, I would add that people used to tear the ovary. Once the cyst is drained, they used to tear. And then we see two layers of the then you can see the cyst wall if it is there. That is the same thing happening here.
Yes, right,
Right,
Mahendra. Yes.
right,
Yes.
right. Nagendra, when you use sutures for coagulation or hemostasis,
So
it
one
depends
thing
on
is
your size of the cystectomy you are doing, or you do it as routine.
So, I do it as a routine. So there are two things when the endometriomas compared to other cysts. Endometriomas are much more adherent. Second is your two raw areas. One is on the ovary, and the second is on the ovarian fossa in case of endometrioma, which is not there in other cysts. So therefore, what happens is so two things. One is, as I said, about ovarian reserve. It is best to avoid coagulation. So there are a couple of techniques. I use 3-0 Vicryl. So there are a couple of techniques described for that. One is taking pursing sutures inside the ovarian bed. So intra-ovarian pursing sutures just to bring the inner walls together. That is good enough for hemostasis. Or sometimes I just take simple sutures just to approximate the tissue together without actually strangulating it. So that is what I prefer. And the second aspect is, one is you lift up the ovary away from the the ovarian fossa for some time. So what I do is, we have those ports come, the lower quadrant ports on either side. So I put a ethylone suture through that and put it through the ovary with the T-lift instrument and bring it out through the abdominal wall and keep it tied for about 4 to 5 days. So when she comes for the suture removal of the skin or the sutures next time, those sutures can be just simply pulled out. What this does is that it keeps that ovary away from the ovarian fossa till epithelialization takes place, which takes about 72 to 96 hours. So these are the two aspects of management of ovarian endometrioma which I use. And the other thing about endometrioma, larger endometrioma, what I do is I just drain them first. So when actually the endometriotic cyst collapses, sometimes you actually get and I claim to infiltrate the vasopressin. So I infiltrated two places out of habit. One is in the broad ligament, which is where the supply starts from, and the second is towards the base of the cyst, where it is thicker, the tissue. So where I often end up getting a much more decent plane compared to the outer thinned out part and adherent part.
So you hang the ovaries for 6-7 days till she comes back?
Yeah, 4-5 days, 5-6 days, whenever she comes back. Yeah, she doesn't know about that. It's the suture on the skin surface at the port site.
Okay.
She doesn't realize that.
Okay, I would like to see that video sometimes. Yeah. Now, my question to all, or Dr. Rajesh can take, when do you prefer ablation or cystectomy, and how much do we need to ablate? How you think it is required in some cases, as experience of Dr. Anuja Kulkarni, who is using a lot of lasers?
Hello, Kalan, I'm audible?
Yes, Dr. Rajesh, sir.
Yeah, good evening, everyone. I thanks Dr. Gore Madam and Dr. Aki for inviting for this panel discussion. As Kalyan said, when you use ablation and when you use cystectomy, see the case of maximum cases where we are operating with the infertility patients. In infertility patients, normally we try to do the cystectomy as all the panelists already discussed. And in case if the cyst is not be able to remove the cyst, but most of the times, though there are a lot of adhesions are there, will be able to remove the cyst. But certain situations, if the cyst is not able to remove, plus if the patient is not an infertility patient or patient is not posting for the IVF patient, in that case we can use little bit cautery and we can do the ablation and leave. But most of the times, up till my experience and all the laparoscopic surgeons' experience also, we can usually most of the times we'll be able to remove the cyst. But in case not able to, then in that situation, in those cases, we can use the ablation. And that too, we can use a bipolar cautery, and that is also very precautious you have to use, because that is going to the coherent reserve will be decreased if you use a lot of cautery and damage. So you have to be really cautious.
Right. Or sometimes CO2 laser can be used for this. Now this question is for Dr. Sandesh Kade. When you use sclerotherapy, you have any experience of using sclerotherapy in such cases, sir? Dr. Sandesh? So endometriomas are drained under ultrasonic guidance and rinsed with ethanol, tetracycline, or methotrexate to induce sclerotic effect. However, the procedure may be useful during the collection of oocytes in patients with reduced ovarian reserve for those who cannot undergo surgical treatment. These are the studies done by Dones et al. Cochrane review said 3 RCTs that excisional surgery of ovarian endometriomas provide a more favorable outcome than drainage and ablation with regard to the recurrence of pain symptoms and subsequent spontaneous pregnancy in women who are previously subfertile. Can you move to the next slide, please? Next, please. Right, next, please. So according to the ISHRE guidelines 2018, when previous one, sir. Last one, sir. Thank you. So level A evidence says when performing surgery in women with ovarian endometrioma, clinicians should perform cystectomy instead of drainage. That is level A evidence, and clinician can consider performing cystectomy rather than CO2 laser vaporization in women with ovarian endometriomas because of the lower recurrence rate of endometrioma, and that is level B evidence. Next, please. So next question is, when you are done an adequate job of doing a cystectomy, when and how you plan pregnancy for such patients? This is for Dr. Ashish Kale.
When you are done a cystectomy, most of them are conceived. You have to go wait for a 3 to 5 months or maybe a 6 months duration. If
You're
in
going
6
to wait
months,
or you're going to give IUI trial for such patients, Dr.
if
Ashish?
it is a unilateral endometrioma, a small size endometrioma, we at least need to give a 2 months for spontaneous conception to occur. And if it is more than that, then definitely IUI, and not only the IUI, it is oral ovulations or maybe a COH IUI will work.
So minimal and mild pelvic endometriosis, excision itself is going to have pregnancy rate. The success rate is more. In patients who have failed the primary surgery, assisted reproduction appears to be significantly more effective in this patient. Otherwise, what recommendation is in infertile women with AFS, ASRM stage 1 to endometriosis, clinicians should perform operative laparoscopy, including hydrolysis, rather than performing diagnostic laparoscopy alone to increase ongoing pregnancy rate, that is level A evidence. And in infertile women with AFS, ASRM stage 1 to endometriosis, clinician may consider CO2 laser vaporization of endometriosis instead of monopolar electrocoagulation, since laser vaporization is associated with higher cumulative pregnancy rate, that is level C evidence in these patients. So now moving to the next slide, please. Next, please. So how we are going to treat infertile patient with recurrent endometriomas in such patients? Dr. Mahendra, sir. Recurrent endometriomas.
Right. My statement for this question would be, if endometrium is smaller, surgery should not be performed, or there is little less role of surgery in case of recurrent endometriosis. We are talking about endometrioma and endometriosis, but endometriosis, there is no role of surgery for fertility purpose. But if it is endometrioma significantly larger, then only we should operate or something, depending on the AMH and other ovary, how is this.
Dr. Harish, what is your take-home message about this?
Yeah, so generally I work with a dictum that, as I said, I require 2 indications for surgery, and we generally give a good surgical workup for this patient. And once operated, the aim has to be increase the duration, the gap between the 2 surgeries. So, any recurrent endometrioma, I would generally not jump in for the surgery, but would try and give some medical management or try and postpone the second surgery as much as possible.
So to conclude this case, IVF is the best option for patients after failed primary surgery. Repeat surgery is associated with significantly lower pregnancy rates.
Yes.
The pregnancy rate after IUI may be increased after surgery only for mild endometriosis. The place of IUI is limited in the patients with moderate or severe endometriosis And in older women, the incidence of recurrence of endometriosis is not increased after controlled ovarian stimulation for IVF. I thank everybody for their inputs. I now hand over to Dr. Sawant sir for the next case.
Okay, now let's move ahead with the next case. Now see, all the panelists, whatever discussion we are doing is related to infertility and endometriosis. Now next slide shows, in fact, the infertility patients with endometriosis, they are good, sizable number. But if you go into the depth of it, the more number of patients, in fact, they suffer because of pelvic pain and dysmenorrhea, dyspareunia, and so many other problems. In fact, sometimes patient will say, Doctor Saab, bachcha baju mein chhodiye, please take care of my own life, day-to-day life. And the time when she is approaching her menses, she gets scared. Isn't it? Have you experienced this? And in fact, मराठीमध्ये म्हणतात, भीक नको पण कुत्र आवर. साहब बच्चा छोड़ दीजिए, मुझे जान छुटा दीजिए. And this is what the next patient has come here. She is 37-year-old patient who is basically staying nearby Mumbai. And this patient, same story what Kalyan has described. Married since 10 years, she came with endometriosis, and that time we have removed the ovarian cyst. But now she says, Dr. Saab, in fact, there is such a severe pain in abdomen at the time of menses. There is a painful defecation at the time of menses. She has dysuria. And of course, she is not allowing husband to come close. In fact, I was little surprised when you said 2 months trial after surgery. 1 month she'll be in her mother's house. She'll be so much worried about her getting pregnant. In 2 months, how she'll become pregnant with the natural cycles? In fact, ovary also must, I'm talking from general OB/GYN's perspective. So you can speak left, right, and center. So this is the patient which is history of lapse surgery, which was done for 5 years back. And now today she presents. She's, in fact, because of this, she has become cachexic. She's not able to eat sufficient amount of food. And this patient has come to us with a lump in the left iliac fossa, bowel problems, bladder problems. And then we did some investigations which sonography showing there is 41 by 14 by 22 millimeter size, relatively ill-defined mass which is felt at the interface between the bladder and the uterus. And this is what is uterine sizes, which looks relatively normal. Of course, they have mentioned small, tiny fibroids here and there. But then, as you know, most of the time, one of the comment which is made on sonography, this most likely represent post-operative something. Just imagine we have to be so much clinically sound, and all of you being so expert handling this case is complicated. We cannot go only by reports, but reports will help us to get more confused. As a result, what happens then? MRI is the best solution. God knows whether it confuses more or whether it gives solution. And then she was subjected to MRI, which is report is there in front of your eyes, which shows T1W image, T2W image, and whatnot, which I do not know how many gynecologists understand this nomenclature. What we read here is there is a left adnexa showing this pathology. Right side, they have said relatively normal. And this is the lesion which is seen at the site of between the bladder and the uterus. Fortunately, there is no hematuria. Why I'm saying fortunately? Because if there's a hematuria, then it's a bladder endometriosis. I think diagnosis would have been more straightforward. So I just want all of you to opine on this case. One, what could have been done better in the first surgery? And as I said, you are sitting all over the Maharashtra, so you can speak opposite to each other. Two, whether Ashish could have done IVF immediately and made her pregnant. Three, whether watchful expectancy is better, we should be more vigorous as far as treatment is concerned. And today, this is what I said, Dr. Saab, forget about the baby, please make me symptom free. That is my goal of the life. I think Nagendra should start first. Nagendra.
Okay. So couple of things. Yes, she was 32 at the time of the first surgery. So probably IVF would have been a better option. I don't know. We don't know about the AMH and all the other factors also that were involved, but IVF would have been a better option immediately post surgery. Second thing is post surgery, we don't know whether there was pre-existing deep infiltrating endometriosis, pre-existing some small bladder endometriosis. So good evaluation, including a MRI. I think MRI is really very important investigation when you have these symptoms, and a good clinical evaluation, a per rectal examination, per vaginal, good per vaginal examination. And if you're good at it, then you should do your own good transvaginal sonography. So these small things, give you a clue to the diagnosis. I had a similar experience. One 36, 37-year-old girl. She just, I had tried, she had undergone 2 scopies, pain like you described. One day she just came and got admitted. I said, doctor, you remove the uterus. I won't go before that. So sometimes you're left with no choice. And the other thing about bladder endometriosis is, I had this very interesting case about a few years ago where no symptoms, only left-sided flank pain, hydroureter, hydronephrosis, MRI showing nothing absolutely. Just clinically, when I did the PV, on the left side there was fibrosis and there was just one retroperitoneal nodule in the distal ureter. So sometimes these multiple things together, and experience, of course. I think probably 15 years ago I would not have diagnosed this. Now I probably will. So all this will lead to a diagnosis. So I think that's the first step. So at the first surgery, was there deep infiltrating endometriosis and was it treated? First surgery, she probably should have gone for IVF immediately since she was 32, 33 at that time. That was at the previous surgery. And now our clinical diagnosis, obviously she has to go in for a surgery. Now the surgery it depends on, we should try and convince her that whether, fertility preservation, excise the endometriosis. So we must give her that option first. But in the more drastic option, sometimes, patients demand that the hysterectomy. But yeah, you're asking something, sir.
Yeah, so no, I was saying, so this one, what we have to learn from your explanation is there is no replacement to your clinical judgment, and we should believe more in the clinical judgment and its experience. In the beginning, we may not be able to pick up the things, and Dr. Krishna's presentation, in fact, he mentioned any abnormal looking spot, not necessarily classically described in the book, could be considered as an endometriosis on scopy in a patients of infertility or pain in abdomen. Such a bold statement, but such an important statement. Abnormal looking spots in the pelvis. Mahendra, yes, Mahendra.
Yes, in this case, actually, now we see like everybody is seeing patients who had undergone one surgery before or something like cystectomy, and then you should be alert that this is going to be a bad case. That is what I assume. And this particular case, as the investigation also showing some bladder, the tissue around the bladder and cyst as well. So first is like to operate, and with good counseling, operate well as an expert, like excision of all the endometrial lesions so that you can give relief to her. That would be the solution from my side.
So, I mean, what are you going to bladder?
Yes, excision of the, evaluate like cystoscopy during the surgery, then laparoscopy, evaluate the depth, remove up to the normal tissue, and excise all the diseased tissues, do cystectomy. Now, as she is like again in agony, that cyst which is increasing stretching, it is going to give her pain again. We can't give like third chance for her for surgery. We should not keep that scope now itself. Then all pelvic deeper endometriosis.
So it's a cystectomy, or you want to remove the whole ovary, which is a pathological, if other ovary is normal?
If they're looking for the pregnancy, you can keep some ovarian tissue. That is fine. It is not that we are going to guarantee there won't be any endometriosis later on. Whatever you remove, there can be endometriosis again in this case as well. If fertility is their goal anyhow, like slight chances they want to have later on, some ovarian tissue, we can get oocytes from that, and then they can conceive with that also.
Harish, you were saying something.
Yeah, generally the ovary which has been operated once, and she is operated 5 years back. So I don't think that the ovary which is now having that same ovary, if it is diseased again, I would generally try and remove that ovary, because it's not going to be, giving you much good oocytes. Even if on stimulation it shows the eggs, the quality of the eggs, I'm sure Ashish would back me up that the quality of the eggs are not going to be great. You can always paint the picture pink and rosy, but generally these patients have it's a disease which is gonadotoxic. If you don't do anything, the body itself is going to kill the gonads. And we see this patient, as you said, patient is cachectic. It's not only the cachexia which is making the patient look like that. It's because the entire system which is involved, the hormonal imbalance and the ovarian dysfunction is so much profound that this patient overall does not do well. I would remove the ovary in this case for sure, which is more than 7-8 centimeter size, and also do the bladder nodule excision, and that requires its own steps, so we can do that.
So this is the right ovary, that was opposite side, the full mass which was adherent. I think Rajesh wanted to make a comment. Yeah, please, Rajesh.
Yeah.
Rajesh, I'll elaborate for your sake in the sense, Rajesh, let me say one line. This
Hello?
patient is in the Latur, which has come, and she says, Doctor Saab, remove uterus also, forget about the ovary. Because in Mumbai, people might say, ki we would like to take chance, we will do X, Y, Z. But in Latur, you know very well, where I also hail from Fulton and that zone, they will say, Doctor Saab, please take out the uterus also, forget about the pathology of the ovary. So what will you do? Then we come to the Ashish for IVF purpose. But about, at least you tell us whether you want to remove the uterus along with the pathology of the ovary. Rajesh.
In this case, is the case of severe endometriosis, and I will counsel her not to remove the uterus because she is infertility. She is 37 years old. Even if she is saying that remove the uterus, but I will counsel her not to remove the uterus. One thing. Second thing, in this case, pre-operative preparation is very important. Whatever you are going to do the surgery, bowel preparation is very important. As you have shown in the investigation, there is a mass in between the bladder and the uterus. There is a left adnexal mass, but we don't know this is a repeat surgery. We might have a lot of involvement of the bowel. So bowel preparation is very important because on the spot you might have to change the surgery. Like suppose there is a resection anastomosis, suppose rectum is opened. With the preoperative preparation, then bowel preparation is very important. Whatever surgery, and this patient will require definite surgery, as all of us panelists will agree. This will require thorough surgery, dissection of the mass between the bladder and the uterus, left adnexa. And if it is an involvement between the rectum and the uterus, we have to remove that also. And in case sometimes it might require the resection anastomosis. So this patient, I will not advise her to remove the uterus. Even if she is asking for that, I will counsel her not to do that. After the surgery, then whatever this ovary, one side ovary looks normal. As this patient, you should go for the IVF as early as possible, because there was a previous surgery. It was done when she was 32 years. Now she's 37 years. She has already wasted 5 years. So after the second surgery, immediately she should go for the IVF.
So very well said. And bowel preparation, I think for all patients of endometriosis is compulsory, because you never know where we'll land up in problem. I came back to this slide because this is what the AMH is, and now we have removed the one side total ovary. Now, Ashish, I just want what is your advice as the AIT consultant for this patient with this report? AMH, which was this 0.8, in fact, that part of the pathological ovary is totally removed, and she is now with you after 2 months.
Sir, basically, when we're talking about this patient, now already one surgery has been done, and second surgery already we had removed the disease, and now the AMH is 0.8. So 0.8 AMH is really this patient come into a Posidian group criteria 3 if she's a 35 age, because more than 35 it comes down to a Posidian group 4. So once this patient is having a poor ovarian reserve, we know that there is a chances of our quality of the oocyte is going to get a lesser number. M2 oocytes at the dual stimulation we had to go. That is where we are going to know about all these things. But mind well, sir, when you're talking about endometriosis, it is not the only the stimulation that makes a difference, because in endometriosis, oocyte quality also hampers. So we need to talk to the patient. Even if we get 4 oocytes in a dual stimulation, or maybe a 6 oocyte, the embryo quality is not the same as the embryo quality which would have been has a tubal factor infertility.
So chances of implantation in those patients are a little bit poor. So we need to talk to the patient whether they wanted to go for dual stimulation or maybe a donor oocyte, and then going for the embryo transfer later on.
So I think it is more aggressive is the better rather than this thing, either donation, egg donation to egg donation, and give her a healthy baby earlier the better, because tomorrow we do not know what will happen to her uterus also. Is Sandesh around? Dr. Sandesh? I wanted Sandesh to come in to talk about these bladder pillars or bladder adhesions, which he is very fond of, and he diagnoses diseases by looking at the peritoneal fold. So is Sandesh, if it's not there, can anyone take it? Can you, by looking at this picture, can you, any one of you tell me whether this has gone inside the bladder and you need a bladder wall excision? Okay, let me go ahead, and this is what the cystoscope is showing now.
You need to do a cystoscopy. Yeah.
Yeah,
you need to do a
Nagendra.
cystoscopy. Yeah, you need to do a cystoscopy. And
This
one
is a
thing I wanted to,
cystoscopy.
yeah, so yeah, one thing I wanted to comment that bladder endometriosis usually does not present with hematuria, usually, because it is submucosal. It rarely erodes into the mucosa and causes hematuria. It's very, very rare. Most of the time they come with repeated urinary infections, something like
Meaning
interstitial
symptoms
cystitis-like
like
syndrome.
urinary tract infections.
Yeah, and bladder increased frequency, urgency. Like that irritable bladder. That sort of syndromes.
Big discomfort.
Yeah. So these sort of very vague symptoms, and it's only sonography which will tell you. And of course, that there is something there. And when you do a cystoscopy, you find a lesion. And at the end of it, you have to treat it like something like a skin tumor or something like a locally growing tumor. You have to excise it with about say 1 to 2 centimeter margin of normal tissue. That is the principle. It's like I always call endometriosis like a borderline ovarian tumor. I compare it with that. It has features of benign and malignancy both. It's somewhere in that borderline, that gray zone.
In medical language, you speak like this. So in common man's, I said naska kanda. So how pasrat jato. So it will start taking the surrounding tissue also. It will start infiltrating the surrounding tissue. Harish, you want to make a comment on this?
Recurrences following good excision of bladder endometriosis are quite rare. Like your abdominal wall endometriosis, bladder endometriosis, recurrences fortunately are rare.
So this is what I just want to Harish to speak, because this is done by me and Harish together, and that's why I thought Harish will be want to add some comments, and in short we can just add up to this.
Yeah. So basically, most of the time we feel that we need a urologist to tackle these sort of pathologies. But when you actually, I have worked with them very close, association. But most of the time, what happens is that the urologist barely know endometriosis. They do not know anything about its natural history, the way the disease progresses and it spreads and all that. So when it comes to tackling the disease in the urological or in the GI also, it's better that most of the gynecologists who are dealing into this type of diseases are well versed with the steps and the of the urological aspects of the surgery. So we perform the surgery. Of course, you need to ideally do the catheterization, but that's not necessary in most of the cases. Very rarely.
Ureteric catheterization you're talking about.
Ureteric catheterization. So basically, or stenting, whatever you call it. Generally, that's mandatory in almost all cases, but you can get away without doing that also. Most of the time, you will see that the endometriosis affects the dome of the bladder rather than the trigone area. And that's what, is the only point that I would like to say.
What I will add here is the way... I'm
sorry?
No, somebody was talking. Nagendra, who was speaking?
Nagendra.
Please go ahead.
I was saying one interesting technique I'd used, I'd learned this from Dr. Pranesha, was that there was this endometriosis which was lying very close to the left ureteric orifice. So that would that I would have probably had to do a reimplantation then. So what I did was, by cystoscopy, by using the receptoscope, I sort of from within the bladder cavity, I shaved that endometriosis from the vesical part away from the left ureter. So that actually, there was quite a good plane. There's quite a good separation between the left ureter and that endometriosis. And then I went laparoscopically and excised that nodule, so I could avoid a reimplantation.
Wow.
In that case. So that is a very
So
that
this
I
is
learned from
through
Dr. Pranesha actually.
cystoscopically you did the shaving
Separated it.
because of
Yeah,
which the
yeah.
ureteric orifice
Shaving means
went little away.
I cut a plane between that, the mucosa, and sort of dissected it away from the ureter on that side, that whole nodule away from that side.
Yeah, like how you do
And then-
enucleation of myoma in
Yes,
hysteroscopy.
yes.
Yeah,
Yes.
similar to that.
Yeah.
So
good idea.
one comment here I just want to make it here is we actually have a big phobia about the bladder, ureter, and we are not wrong because we are not trained that way. So to come out of that phobia, basically we need to witness more and more cases. We need to see more cases. Then over a period of years, I think we might get rid of this phobia. Mahendra, you were talking something?
No, I just had an opinion that when you're doing
That is what we
endometriosis,
want. Opinion is most important. Yes.
just a comment that when you're ready to operate the endometriosis, suturing the bladder and bowel should be as fast and confident as you are suturing the vaginal wall. That is what I would comment. You should train or have that attitude.
Okay. Thank you. Very nice. Very nice. So I think with this, we go to the next case, which is the complication of the endometriosis surgery. And I think I'll request organizers to tell us 5 or 10 minutes before, because this will go on. And I think all of panelists had food, so they might continue like that. Now, I just want to know this endometriosis. The endometriosis, is it that it's common in nulliparous, it is not seen in multiparous, the severity is more in nulliparous, it's not seen in that severe in multiparous? So can somebody throw light on this? Nagendra might be with now your so much of gray hair, of course less than mine, but you can comment on that.
Sorry, I didn't get the question. Can you just repeat it?
I mean, this severity of endometriosis, is it more severe in nulliparous patient as compared to the multiparous patient? And is the multiparous patients immune to develop the endometriosis?
No, I don't think so. Now last few years, I have seen so many patients with previous, in fact, just a couple of days ago, I did a hysterectomy on one woman at Thane, in the Jupiter Hospital, and previous 2 normal deliveries. And so basically surgery was for adenomyosis, hysterectomy, and such bad, deep infiltrating endometriosis everywhere. So, it's a myth, I think. It's a myth.
What's she from?
I think we
south of India?
don't know. We probably don't, we are not aware. Probably more often than not, we are not aware that the existence of the disease. You assume
I made one comment whether she was from south, because I think if you analyze the whole country, more of this is seen more of a south than compared to the north. I'm talking about the multiparous patients. Others are free to make a comment.
I agree, Dr. Ganpat.
And in fact, there was one interesting video I have somewhere. This was a patient who was for an ovum pickup. She was a case of MRKH syndrome. No uterus, no uterine buds, nothing, no rudimentary horns, and she had she was for an ovum pickup. I don't remember why I was doing the laparoscopy. It was for somebody else, but the scopy, she was on HRT, obviously. Sorry, she was a case of ovarian failure, a premature ovarian failure. Therefore, she was on hormone replacement therapy. So we were doing a scopy for something, and because of long-term hormone therapy, she was about 25 years. We found spots of endometriosis in the pouch of Douglas and on the uterus.
Oh.
So you know how hormones can contribute to evolution.
Okay.
And probably it's pre-existing. Yeah.
In fact, Ashish, unmute.
Yeah, sir, I think what Nagendra is telling, no, this is nothing to do with the hormones. Nowadays, there is a theory of genetic predisposition.
Yeah, absolutely. So that's what I'm saying. How it helps
much more larger theory.
No. Yeah. So how that it is already pre-existing, and now these hormones are giving that little push for it to grow.
Yeah,
that is what I want
true.
to imply.
Yeah, Harish.
Yeah, okay. So I want to say about myoma and endometriosis. We as a medical fraternity do not know any cause. And we as a medical ego, we have such a big ego that we can't take as no reason as a reason. So we want to label it to either genetic, environmental, these, that. But in my view, endometriosis does not obey any rules. It does not obey any rules. It breaks all the rules.
You mean females? Sorry, endometriosis.
Tomorrow you might find Nitin Shah posting a video on saying first male endometriosis operated. So you never know.
I know.
Sir, there is a study, sir, which definitely quote Harish that if the newborn babies if they have the menstruation or blotch. And those females are likely to have the endometriosis more chances in their reproductive age group. So definitely, when there is a higher estrogenic environment, or maybe at birth also, if they has
I'm not denying that there cannot be genetic predisposition. There cannot be environmental factor. But in one particular patient, suppose a patient comes and visits to you, say Savita. Now that Savita, what cause she has, can you pinpoint? No.
Yeah.
So that's what I'm trying to say.
Yes.
As a disease, we can say there are many causes. But as a patient, we can't pinpoint what causes are.
This month is endometriosis month all over the world.
Yeah.
Very interesting month in the sense, one of the causes of late detection of endometriosis is lack of awareness.
Yes.
And in the first lecture, Dr. Kulkarni put it so nicely, just because sonologists say there is no pathology found, and that's why the endometriosis diagnosis is delayed by 8 years. Just imagine the radiologist saying that. And we depend so much upon the radiological findings to find out the pathology. So one of the meetings on endometriosis, which Ashish was participating in the panel or debate, that madam said this: if the newborn baby has a spotting, which some of the babies, female children, they show, she is the candidate to develop. So in that way, just because you started this discussion, does the female who has an early puberty, early menarche, is likely to have endometriosis more? Or those who have a delayed puberty is going to have a late, or less chances of having endometriosis?
Not all. This becomes a theoretical discussion, I think, sir.
Yeah,
and
absolutely,
you said in the beginning.
absolutely.
I'm just
So
trying to
let's keep it on one side
to the moderator.
Yes, let's
keep
keep
theoretical discussion.
Let's keep it on one side. So this was a multiparous patient and very interesting patient, which I thought. So this was a 45-year-old lady who had 2 normal deliveries and TL done, and then she presented first time with ovarian endometrioma, for which she was operated 12 years back. Since last 12 years, she was absolutely fine, nothing. And last 2 months back, she came with a severe pain in abdomen. Just before that, I just want to mention that time when she was operated for ovarian endometrioma, post-operatively on day 7, she developed ovarian abscess, which was aspirated under sonography guidance. And I think you people discuss about the sclerotherapy, some agent was injected at time. And she was asymptomatic for last so many years, that is almost 12 years. And suddenly she came with pain in abdomen, and this was done. MRI, CT scan, sonography report, I could not put it here because I failed to get it. But it showed a left side big cyst having inflammation or inflammatory collection suggestive of pus. Right side, it was endometrioma, collection suggestive of endometriosis. And I think I'll go a little quick. And this is what the findings. I do not have a videos, but these are the pictures which was seen. This is a fountain of pus which was seen. My question to all the experts is this a condition which is occurred is related to the previous pathology? One, if not, what could be the reason today to develop? And whatever comments, experts comments you want to make it. Starting, I think Harish will be last. Nagendra again.
So yeah, but I have seen cases of spontaneous infection in endometrioma. Don't know whether it is reactivation of old infection, presence of like PID. Sometimes you just don't have explanations many times why PID occurs in some patients and why it doesn't in others. Some local immunological factors, whatever. But I have seen cases. I have seen a couple of cases who have developed severe pelvic infection following aspiration of endometrioma, and I have done a couple of cases where patients have spontaneously developed abscesses within the endometrioma. So whether the fluid itself, sometimes there's a breakage in the immune barrier, and the bacteria are able to access that fluid, and obviously once they access that fluid, it's a wonderful place for the bacteria to grow. So your guess is as good as mine.
Okay.
Right.
And the other thing is,
without
like, sometimes what happens is one last thing. Sometimes these endometrioma, as they grow, they start leaking out sometimes. So you find, patients with endometriotic fluid all over the abdomen when you put in the scope. Maybe this fluid can, it's there, so it's there for getting infected.
Mahendra, yeah.
Without aspiration as well, sometimes we have found that pus in the ovary. So it is somehow like activation or new formation of infective focus in the ovary and causing pus collection. That is what we have observed. So not necessarily there has to be something, but in this case, I don't know whether she has already undergone once that sclerotherapy and aspiration and all those things. So that is one history in this patient now.
But that was around 12, 13 years back.
Yeah. Right. So
Very long time.
It may have got activated for some reason. Like I could see that reason in this patient. That is the best culture anyway. So if she starts getting some hemorrhagic cysts and that previous infection again reactivated, it can cause like massive pus formation in that cyst.
Okay. Rajesh is there. I mean, is this such kind of cases are seen there in rural India?
There are cases, but in this case, there was 12 years she was asymptomatic. So it's less likely that there is a recurrence of previous one. As Mahendra said, it may be fresh infection also. That can, most of the times after the aspiration, immediately it will occur, maybe within 1 or 2 months.
I also think so, because it shouldn't occur after so long, isn't it? Because
12 years she was asymptomatic. That means this must be the fresh infection.
Fresh infection. Yeah, Harish, you want to add something?
Yeah. So first of all, whenever you see ovarian pus, the thing that as everybody is of opinion that the previous aspiration can cause ovarian empyema, then it comes generally within few months. And of course, within few months, the patient presents with, and it can keep on growing. I would differ with the opinion of Nagendra that the leaky endometrioma can cause pus formation. No, generally enclosed endometrioma is more likely to get infected and not the leaky one.
I never seen a
If
leaky
you
one
have
get infected.
associated bowel adhesions around the ovary, like appendix sticking to the ovary, there is a very high chance that this patient is going to come back with the empyema. So in this particular case, I would say that it's a de novo infection and not at all related to the previous aspiration at all. And associated, if there is appendix or something, then you have to rule out that. Or if there is a bowel really adherent closely, and sometimes it's just leaking. There is a leaky gut syndrome and leaky peritoneum syndrome, and these are certain new things that we keep on hearing and should know about this thing. And then it can cause infection because of that.
Can you tell us
And when you're tackling with an
1 minute,
empyema,
what is that leaky gut syndrome? Just what is it? Can you tell us that? What is it?
So leaky gut syndrome and leaky peritoneum syndrome are seen quite commonly. Leaky peritoneum syndrome is the patients who come post-operatively, and most of the time it is labeled as because of glutaraldehyde that we use to chemical sterilize our instruments and not wash them very well. Some glutaraldehyde go inside and cause chemical peritonitis. This patient generally presents with pocketed empyema, pocketed ascites, which takes generally 3 to 4 weeks to resolve. And most of the other findings will be normal. So the patient's presentation is like a sepsis. So this is leaky peritoneum syndrome. You can find out about, there are multiple papers on this. And leaky gut syndrome is, sir, when a patient has a mucus. You said patient has a mucus passing in the motion, right?
That was the previous
in the history, Oh, okay. Sorry, I'm mixing up. I'm so sorry. Yeah.
No, we'll stop soon. Don't worry. We'll stop soon.
Okay. So basically, if the mucus lining separates the bowel content entering into the mucosal layer of the bowel. So if there is a impairment of this mucus, then these patients have the intestinal content going through some injuries or some breakage of the cells and going into the peritoneum. So it would not lead to peritonitis, but can cause lots of microbiome changes. This is a big thing in celiac disease, ulcerative colitis, and leaky bowel syndrome is one of the known facts now.
Okay. So
Yeah.
we come to the last few slides, and I just want quick opinion. Is there still a role for laparotomy for severe endometriosis? Rajesh bhai, we can't operate the way they are operating. So I just want to know the opinion of experts, whether there is a place for laparotomy for severe endometriosis surgeries, whether it's a hysterectomy or a big tumor or a big masses to be removed.
So nowadays, all the laparoscopic surgeons are everywhere. Not in smaller places also, they are doing quite advanced work. So there is no role of laparotomy as such. But if there are surgeons are not there available, they are doing the basic surgery. Then in that cases, you have to do the laparotomy. But most of the times now, even the smaller places like Tehsil place, Taluka places, also the people, a lot of young generation, they are doing quite good advanced work. So I don't think so. Suppose in one place, suppose it's not operable, they can refer to the district place and get it done by the expert surgeon. That's
So
my
this is
opinion.
what you are talking is absolutely ideal. But now it happens, I have opened and I am in deep trouble. That person is not available, not contactable. My judgment is wrong. Something has gone wrong. So, I mean, we should be,
In such situation, definitely I'll call the surgeon for my assistance, and both of us will do the surgery, whatever is possible by the laparotomy.
Okay, okay. Anybody wants to make a
Sir,
comment?
sir, can I talk?
Please, please.
Yes, sir. Sir, the gone are the days, sir. You also in a medical college. I had learned from the medical college, all of us. If there is a something dissection deep down in the pelvis, for a laparotomy, it is very difficult to go and address that issue. Even if it is a CS cervix or whatever it may be, only that person is knowing what he is doing. Rest of us are just assisting whatever the way he want us to assist. But in the laparoscopy, I think, sir, most of the things is the vision is the clarity. We know very precisely what we are doing. And I think with the 4 ports or maybe if additional port, if someone wants to have, it can be done effectively as much as it can be done in the laparotomy, because laparotomy, again, the plane dissection and everything is much more difficult. You cannot see precisely rather than on the laparoscopic view.
In short, on laparotomy, you may not see everything which is seen by the scope, and you will be able to operate it better way. Just quick comments on this again. What is the role of this lunar presacral neurectomy, and not last part? Does any one of you doing these cases regularly? Laparoscopic uterosacral nerve ablation, and for what indications? And is it effective? Frank opinion, please, no theoretical.
Yeah. So basically, sir, now we are going towards nerve preservation surgeries for endometriosis, and we should not talk about nerve ablation. So rather, it is like punishing somebody else for it's like punishing the person who's suffered a who's lost his pocket by a pickpocketer, and ask him not to keep a pocket at all the purse ever, so that it will never be picked up. So I think the nerves ablation it used to be done very efficiently, and it showed good results in some patients, but in my experience, I think it should not be done. You should address to the disease better and much radically, rather than doing the nerve ablation.
Very good, very well said.
Yes.
Anyone
Remove the
has
disease.
any
Remove
different
the disease, simple. Remove the disease. That is the principle.
Okay, I think we should close here, and because this is all theory which is discussed, only one point is about this microRNA, that if anybody has something about this, I think Ashish will add on this, because we are not able to diagnose this condition properly, and that is one of the reasons why it is being delayed diagnosis. So this is something new. Can you make a comment on this?
Yes, sir. Sir, microRNA nowadays, like what we was doing is a CA125. That can be inflated in any of the condition. Maybe epithelial tumors also have the higher incidence of raised CA125. But once you do this microRNA, which has a very specific, and they are given us a recurrence rate also. If your microRNA, if you are doing it now, and if it is on a higher side, if you finish up the surgery and do it after 1 month, and if still it is on a higher side, the patient has to counsel that there is always a chance of the recurrence in that matter.
Very well said. Very good. So I think last closing statement from each of one of you if you want to add something. Otherwise, we close the session here. And Mahendra, you want to say something before we sign off?
No, about endometriosis, for fertility, we have to be little conservative. And for pain, because these are the major symptoms with which patients come to us. For pain, you have to be radical as much as possible, economical radical, as you can say. But for fertility, be little less surgeon. That is what I would say.
Yeah, Mahendra, I would just comment on that. So the line between the radicality and the preservation or a conservation is so thin in endometriosis that actually it's very difficult to stand on that line. So, I mean, of course, it has to be a tailor-made approach. What is patient's priority has to be discussed first. If the patient is okay for recurrence and want to have baby of her own, then I think what Mahendra said is very, very true. But what I feel is that preoperative counseling is most important in dealing with the patient. You should not do what you can do in the patient, but what patient wants in the patient.
Okay, thank you very much. And I am missing Sandesh because I wanted some
even
input
we are.
from now preservation. By this time, he must have had food. I don't know whether he had joined back again. But otherwise, thank you very much, all of you. It was
Thank you so
nice
much.
panel discussion. And I must say, you have given a lot of good inputs. For example, that AMH point which you said ki immediately we should not do a AMH because it's bound to be changed, and after 2 months of the surgery you should check it. That is a very important point. New thing which is coming is microRNA, not only one thing, that is CA125. One comment, because I think there is somebody is asking question continuously, that question is coming about one comment on adenomyomectomy or adenoma resection. And Ashish, you want to, I mean, you have to say something about pregnancy outcome after adenoma resection, because that's a comment which is coming, and we must respect delegates' comments because they want to know about this. So please, all of you, one line you can say about adenomyoma removal, whether it's local or a generalized, what will you do? And Ashish, you can talk about IVF or whatever you want to say. Implantation failure are the main question. So starting with Mahendra, chalo, start.
About a generalized adenomyosis and fertility, we are helpless actually. As a surgeon, we cannot do much to the patient. It's only some drugs or some molecules will help her. That is what I would say. And for adenomyoma, we should operate for pain. If it is smaller, neglect it. That is okay. But for larger adenomyomas causing severe pain, then give a relief and then go for the treatment. Still, she will need the molecules again.
Okay. Yeah, Harish.
Sir, Mahendra, you said it very well, but generally, unfortunately, there are no two group of patients visiting our hospitals. The patients generally have a mixed disease. So, Dr. Sanjay Patel has devised a fantastic classification which is not known to the world, not being practiced. Only Sanjay Patel and his followers are practicing it. And I feel is that preoperative, So, you have very pure adenomyomas, wherein you go in as a myoma on sonography and you find that it's too difficult to handle. There is a chocolate cyst inside or something, which was missed on probably on sonography. And these are the patients have fantastic results, both surgically as well as, fertility wise. Then comes the other group, which is having a mixed type of disease, wherein you have a localized disease, a focal and a local, both. Means focal, first one is focal disease, second one is local and diffuse disease. And the third one is what Mahendra was saying was a diffuse disease. When the diffuse disease is there, generally the chances of this patient conceiving and having symptom-free life is really very difficult. But when the patient who is in 20s comes to you with say around 20, 22 week size uterus and with severe adenomyosis, I have had a couple of patients like that who have been operated twice before and done nothing for it. This patient still opted for only adenomyomectomy despite sitting with them 1.5 hours of counseling. This patient, I personally would have done hysterectomy. And you know what? To the surprise that these such patients have conceived. So, I mean, I would not say that the hysterectomy is the mainstay or a final step. Do as what I said, as what patient is ready to, accept as her outcome. You explain to her that these are the things that we see generally in most of the patients. Post-operatively, you may not do well. The results will be very poor. And if the patient wants to accept it, fine, go ahead with that. That's what I feel.
Okay, Ashish.
Sir, as far as the IVF is considered, these are the patients. We have to group into two. One with the adolescent endometriosis, and the along with its adenomyosis, and another is in the reproductive age group where they have adenomyosis along with the endometriosis. Those are the patients, sirs, when we are talking about focal adenomyosis, which will have a better effect with the medical line of treatment. So you have to do one thing is a stimulation of the patient, cryopreservation of all the embryos what we have, and give a GNH analog or maybe a diagnosis for a longer period. Come back to the see whether the volume of the uterus has come back to the normal or near normal. See, in focal adenomyosis, even if you do a surgery or even if you do something like it is going to work, but if it is a diffuse adenomyosis, it is not going to work. In a diffuse adenomyosis, you need to give a medical line of a treatment. See for the volume reduction. It definitely suggested if the volume of the uterus come back to the nearly a normal, it may never come to the normal, because in IVF with the adenomyosis it's difficult to achieve the pregnancy. They will have the pregnancies, but implantation failure is much more higher. So in those patients, you give a longer duration of a GNH analog or maybe a dynogest, see for the volume reduction of the uterus, and then do a implantation.
Very well said. Very well said. So do some vigorous treatment, get her to temporarily normal situation, give her a baby, and then let's see whatever happens. Anyway, very well said, all of you, because finally we are not the dictators. And no, you need to remove uterus, you need to do this. We can't say nowadays. We have to discuss pros and cons with the patient, and whatever after understanding both the sides, whatever decision she takes after understanding the whole thing, we have to go with her, because all the time our decision may not be correct, and that is what is the most important. I must thank for all your inputs. They were very valuable and pertinent. Your thoughts of our subject and understanding and the knowledge was really fantastic, which made us aware so many other new things. So I'm truly humbled and honored to be a part of this discussion. Thank you very much. And let me thank, along with my co-moderator, Dr. Kalyan, to thank President Dr. Swati Gore and President Secretary Logs Dr. Rakhi Sarda for giving us opportunity to moderate this session. Thank you very much. Thank you very much.
Thank you, sir. Thanks
Over
a
to
lot.
you.
Thank you very much, sir. Thank you so much.
Thank you.
Thank
you,
you, sir.
sir.
Nice
It was,
moderation.
Thank you so much. Thank you.
Was
it's,
excellent.
it was a super panel discussion, sir. You have been explained taken from minute, from mild endometriosis to the severe endometriosis, sir. It was an
Thank
excellent
you.
panel discussion, sir. I
This
being
is the
a
cream. This is the panel, whatever there you have seen. This is the cream of India. We are proud of them. There are so many others. But if you see the work which they are doing, including your Krishna, it's a fabulous work, and the quality of work done is tremendous. And the concept which they have phenomenal. So we are really lucky to have them today, Sunday afternoon. I'm sure their BB must be behind their back. Jaldi khatam
yes,
karo.
sir.
But yes, it was nice and we really enjoyed. Thank you. Thank you,
Thank you,
everybody.
sir. Thank you so much.
We would like to see you all physically in Latur.
Yeah,
Call them, they will come.
Sure. I've been in fast. We'll be again there. Sure.
And without fail, we must thank a big man behind the big lady. That is Dr. Suhas Gore, husband of President Swati. He was
Oh,
also
great.
very much after us to mobilize these people. So thank you, Suhas, for inviting us. Thank you. Thank you.
Thank
Come.
you.
Thank you. Thank you, sir. Thank you.
Thank you.
Sir, I would like to take your 2 minutes. Just as a formality purpose, I'd like to give vote of thanks, sir.
Okay.
Just to conclude our webinar, sir. We have been fortunate to have a renowned identity from the field of academic of endometriosis. I thank all the faculties from Mumbai, Pune, Aurangabad, Sholapur, Latur for taking out the time from their busy schedule and sharing their valuable knowledge with us. The webinar was fully loaded with the knowledge and had also a quiz session also. I am very pretty sure the precious knowledge, tips, tricks shared by our moderator, Dr. Ganpat Sawant sir, Dr. Kalyan Baramde sir, and our panelists, Dr. Vagasia sir, Dr. Sir Deshpande sir, Dr. Kade sir, and Dr. Kai sir, Dr. Borse sir, and Dr. Rajesh Dode sir will definitely help us in our day-to-day practice. I'm also thankful to my MMC observer, Dr. Deepak Gugle, for joining today's webinar. I would also like to thank my chairpersons, Dr. Bhalchandra Madam and Dr. Jaju Madam, for carrying out this session in a smoothly manner. I also thank to all my listener participants for attending today's webinar and making a grand success. Without you, it would not be possible. I thank my moderators, Dr. Prachi Ruikar and Dr. Sapna Nilingarkar. Not the least, I would also thank Mr. Amit Rai, RSM of Sun Pharma, for sponsoring today's webinar. And also the technical person, Mr. Kishore, for solving the problems in the fraction of seconds and not letting us to wait for the longer duration. Thank you all. So
Sandesh, we missed you. Sandesh, we missed you. That bladder endometriosis is waiting for you with those 2 folds. You are those 2 folds, Sandesh's folds. We wanted to
I'm
listen to
really
you.
sorry. I was called for an emergency. My friend was operating, and so I had to rush there. But I was always there from the morning sessions, right from Krishna's lecture and previous. And I congratulate Latur Obstetric Gynec Society for this today, March being the endometriosis March month. We are trying to learn and help these patients. So I really congratulate you all for conducting such a dedicated endometriosis workshop.
We'll keep separate session for you, for your pillars only. No problem.
Window. Sandesh window.
Thank you so much. Sorry, I was in an emergency. Sorry.
Thank you, everybody. Thank you. Thank you, Swatima.
Thank you, sir. Thank you all.
So we'll leave. Thank you. Thank you, everyone.
Thank you.